Don't waste my time with this. Can't marry. Can't marry. Can't marry. Don't waste my time. You reality. Can't marry.
Muhammadai, Habat.
Thank you so much. For those who are still standing, I'll humbly request everyone to actually get to their nice seats that are prepared for them. And hear me out for this story. We're kicking off with the story, and I'd like to tell you actually a story as we start this day. 12 years ago, myself, who is standing here, I got a privilege to own my first mobile phone, a cell phone. And as you could actually relate, my cell phone was not the fanciest phone that you can ever have. It was as tiny, a little bit creepier, and had two things in particular that I want you guys to note. The first thing, my phone could not go in a vibrating mode. It only had to ring or to be in silence. So there's a time whereby I was in church and a family relative called me, and the whole church started singing the song of a famous artist. You can imagine as a teen which song that was there. However, little did I know that today, the same gadget that I used to fear and the same gadget that embarrassed me in a church can actually be a tool to use to almost everything that I'm doing in my daily life. Except seeing a patient because I'm a doctor. But things have changed out. We've come to an I don't know if I'm being too loud for the microphone. However, I'm saying that we've come to an era where a cell phone can tell me the dose of a medication that I need to prescribe for my patient. A cell phone can remind a patient the time to go to our next appointment. A cell phone can help us manage a pandemic like COVID, whereby now we're carrying our COVID vaccination card in our phones, whereby today we got tested and the phone is the only tool that we are using to share the message that we are COVID negative. We are in a digital revolution, and that's why today we gathered again to see how much our health can actually use a digital revolution to improve our health systems. Is there any other time that this topic can be as important as it is today? I'd say no. This is a very timely discussion that we are going to have. Just as a reminder, today we are here, gathered for the second symposium for health policy symposium. The first edition happened in 2018, and today we are in 2022 for the second edition. And the theme of this event is none rather than digital solutions. Digital solutions. So we're going digital. That's why you did not see any printed agenda. Did you ask yourselves, why don't we have this folder of agendas printed for us? No, we're going fully digital. We're going fully digital, and we thank RBC for hosting and actually making us gather for this amazing event. Ladies and gentlemen, for those that came late, my name is Magnifique Irakoze. I work with the University of Rwanda in the Department of Obstetrics and Gynecology, and I am stationed on a daily life at Kigali University Teaching Hospital. That's what I do in a daily life. But today, I am going to be the master of ceremony. We are joined by different dignitaries, the guest of honor, representing the Minister of Health, Honorable PS. We are also with other government officials, and we're going to welcome each and everyone in the due time. I'd like to start with few housekeeping remarks. As I said before, this is fully virtual. We have both the online participants that are listening us from different remote places, and we also have us here who are gathered in this room to share about what is going to be on the menu in the coming few minutes. The other thing, we have an abstract book. We have a committee that has worked tirelessly to put up great materials that we're going to use in according to this particular conference. Please check out, every participant was sent an abstract book. If you didn't get it, please go to my far left up there, and you get assistance about getting the abstract book. The other thing, we want, as this event is virtual, we know that there are people that cannot make it here. So please let us trend on social media. We've got a hashtag called Health Symposium 2022, and we're going to be tweeting. Please retweet us. Hashtag Rwanda, hashtag RBC, hashtag Rwanda Health. Please tweet us and let the people know that we are digitalizing the health systems, and it is now or never. So without taking so much of your time, allow me to welcome the chair, actually the person who is behind the minds that has prepared this conference. So it's none rather than Professor Claude Mambo Muvunyi, who is the Director General of Rwanda Biomedical Center. He has more than 10 years of technical and managerial and strategic experience in the field of clinical and public laboratory medicine, with a special focus on clinical microbiology, laboratory systems, and service strengthening and global health security. He's now a full professor in the clinical microbiology and laboratory medicine. He holds a degree in general medicine from the University of Rwanda, a specialization and PhD in clinical microbiology from the University of Ghent in Belgium. He also holds a master's in medical biology from the University of Manchester. He is a well-achieved person, and he's at the helm of leading our healthcare systems. Sir, the floor is yours. Thank you.
Good morning. Thank you very much, MC, for this nice introduction. Honorable PS at the Minister of Health, PS to Minister of ICT, Executive Secretary of the National Council for Science and Technology, representative of UN agencies and all our NGOs and partners, dear stakeholders, Director General of Hospitals, dear colleagues, students, residents. On behalf of RBC and myself, I'm really delighted to welcome you all today to the Health Research and Policy Symposium, and a very special welcome to our guests of honor, our honored keynote speakers. So thank you very much for joining us here and also remotely following up this conference and symposium. So today marks the second edition of the Health Science, Health Research and Policy Symposium, initiatives established by the Rwanda Biomedical Center in the framework of promoting local research and its translations into policies, practical implementations. So the 2022 Health Research and Policy Symposium is a multidisciplinary gathering that brings together key players in the healthcare sectors to reflect and discuss on the translation of research evidence into policy making and implementations. So it is really a platform to share and discuss evidence-based policy making and practices and discuss related challenges. So this here symposium has been termed Digital Solutions and Innovative Practices for Better Health, to really highlight the increasingly undisputable role of digital solutions and the importance of innovative research methods to face these areas of health challenges. So digital solutions need to be implemented at each level of the health sectors, from disease prevention to diagnosis, treatment, but also the long-term management care. So we all know that the COVID-19 pandemic has been among the most disruptive public health emergencies, which could not be addressed by conventional means. An effective and timely response to the pandemic required new strategies and also unprecedented interventions, while existing efforts to sustain other diseases and also to maintain those programs that has been maintained. So the digital solutions play a crucial role in the country's response to the COVID-19 pandemic at different levels, from reinforcing infection prevention measures and also screening to case finding, and also patient isolations and follow-up, but most importantly, in the COVID-19 data management. Continuous innovations, digital solutions, and the implementations have been imperative for generating quality and timely evidence that informed response decision. So additionally, the digital system we implement should all allow robust data analysis to face the growing amount of data generated from different sources, such as electronic medical records and also image databases. Innovative research methods should really prioritize digital systems to streamline evidence from big data to inform health interventions. So in light of Rwanda's remarkable achievement vis-à-vis COVID-19 response, and also the efforts toward meeting sustainable development goals, Rwanda focuses on maintaining the momentum and also continuing to improve access to equitable and quality healthcare services for all. A particular emphasis for the second edition of the Health Research and Policy Symposium is to really showcase the role of digital solutions and also innovative practices in addressing health matters. So this symposium will provide a platform for key players to reconnect, celebrate achievements, discuss collaborative opportunities, share lessons learned in digital solutions, and also innovative health practices. As I conclude my remarks, I would like to really express my sincere appreciation to the organizers of this symposium, including University of Rwanda, the CHAI, and also PIH, and all other stakeholders for a successful event. I also would like to thank everyone for bringing their expertise, experience around a high-quality keynote talks, research abstracts, and also posters, and also engaging in such fruitful, constructive, and also open research exchange throughout the 2 days of the Health Research Policy Symposium. So again, thank you all for contributing to your valuable time, providing steer on this remarkable event. I invite you all to enjoy the symposium, and I wish you all a very good health. Thank you very much again, and I wish you a productive and also insightful symposium. Thank you very much.
Another big round of applause for the DJ for those nice words. He said that this is the time to translate lessons learned into solutions that are going to profit our health systems. And I would say that this is the really time that we need to do that. Talking about digital, I remember by the time we started actually putting digital solutions into practice at a place where I work, so many people are actually resistant at first. But they actually get to go through, because some of the time it's actually a law and you have to admit to that. So now that as the people in the medical field, we tend to get reluctant to join the digital world. So to this extent, we actually have this platform where the healthcare providers meet the people in the digital era. That's why for this opportunity, we are not just here as people in the health systems, but we are here with the very other important people who are actually going to make us less scared of when they talk about tech. So I'm going to have this opportunity and a privilege to welcome the Permanent Secretary in the Ministry of ICT, who actually joined the public service from the Alan and Gil Gray Philanthropy, where he served as a Rwanda country director. Prior to that function, he was a senior director at Mass Design Group, a global design firm with office in the US and Kigali. Iradukunda's role at Mass included oversight and operations across global office and the coordination of design and construction projects. He is a young person, very energetic and friendly, and who is actually going to make us very conversant with tech. Let's welcome Honorable PS with a hand of applause. Thank you.
Am I audible? Okay. What a warm introduction. Thank you, MC, for bringing the energy in the room. Dear PS, Minister of Health, Director General RBC, Executive Secretary from NCST, distinguished guests, ladies and gentlemen, all protocol observed, good morning. Indeed, MC put it right. We are very honored and pleased to join this symposium. And as a ministry responsible for digital transformation, this health research and policy symposium topic could not have been well chosen to tackle the topics of digital solutions and innovative approaches. On behalf of the ministry and the minister who could not join us this morning, we wanted to commit once again our partnership and collaboration when it comes to working with the health sector to make sure that we bring digital transformation and digital innovation within healthcare space. Innovation that leverages digital technology, indeed, is capital for us to accelerate socioeconomic development. As you know, the government of Rwanda has been consistently investing in the adoption of advanced technologies over the years, and this has really helped improving efficiencies of our processes, as well as innovating toward better services for citizens and overall enhancing our competitiveness. As you know, and you've been a part of this, our approach has been really to streamline digital transformation as part of national and sectorial strategies. And this has already seen how we can formulate initiatives and plans that can indeed move us forward. This has also been combined with creating enabling environment for innovators and startups that support government efforts through the relevant policies to support innovation, including sandbox frameworks, the deployment of dedicated innovation spaces across the country, and growing more opportunities for startup financing. In our priorities, the digital transformation of health sector has always been a key pillar of our digital strategies. And over the years, the overall aim is to widen access to quality healthcare services, improving patient experience, and enhancing clinician productivity while lowering the per capita cost of healthcare. Today, the digital transformation in healthcare is not a choice. It is an imperative that is forcing caregiving organizations in all countries to shift to offering high-value patient and clinician experiences. We have witnessed so far great initiatives to digitalize medical electronic records at different levels, deployment of different data-powered solutions to support healthcare delivery and decision-making, and to empower evidence-based policies. And this does not leave behind the management of emergencies, including the recent COVID-19 pandemic. Technology undoubtedly proved to be a great ally to help ensure that government is making a difference on the front line of the emergency, while also continue to provide essential public services. Several initiatives were put in place, including AI-powered chatbot to provide timely and accurate information on COVID-19, contact tracing applications, digital reporting surveillance systems, usage of data visualization and analytics to monitor cases and focus public health interventions where the evidence of community transmission and different IT tools to support mass testing and vaccination. Also, through partnerships with local and foreign innovators, we have promoted innovative initiatives and concepts such as using drones to deliver critical medical supplies, including blood products, drones to combat malaria, digital consultations being enhanced with the use of AI in medical triage, advanced data analytics and robots were of great help as well to support fight against COVID-19. We aim to continue in promoting such innovative partnerships, and we invite more players to partner with us to try new ways to deliver quality healthcare while we continue to accelerate the transformation of service delivery in the health sector, also enabling full digitalization and integration of existing health systems, as well as continuous investment in ICT infrastructure to support such systems. Together with the Ministry of Health and affiliated institutions, we started by putting in place comprehensive integrated digital transformation strategies. This included a digital health reference architecture for Rwanda and the corresponding implementation plan that spanned over 5 years. Together with the Ministry of Health, we have recently mobilized significant funding with the support from the World Bank through Rwanda Digital Acceleration Project, as well as other funding, but particularly this project brings more than 12 million US dollars to be invested in a flagship healthcare sector digitalization initiatives. This will allow us to continue the transformation that we talked about of service delivery in the sector, and also making sure that all these systems are integrated. The support that we need to continue to bring into the healthcare digital transformation is anchored into a blueprint, and this allows us to really have clear data management, interoperability standards, and sectoral enterprise architecture, which is already developed in partnership with the Ministry of Health and RISA. And my colleague, Antoine Sebera, the Chief Government Innovation Officer, will be later on the panel highlighting the various initiatives that are laid out within this blueprint. We believe this particular project, combined with other existing projects within the sector, are putting us on the right track to achieve the full digitalization of the healthcare, of the health sector, and also in supporting other efforts towards meeting Sustainable Development Goals. I thus call upon the health research community attending this symposium, as well as other stakeholders, to join in these various efforts that I have highlighted. MC did mention that at the beginning, there was even fear to use these technological systems and tools that indeed empower the quality of service delivery. I therefore again invite all of you here present and those that are following online to call you to take on this call of joining our hands and our efforts to ensure that we achieve more heights and success stories in the healthcare sector using digital technologies. Once again, I take this opportunity to thank the Ministry of Health, RBC, for inviting us to be a part of this and picking the right topic that really addresses the core of the challenges that we have. And I wish you a fruitful session today, fruitful discussions, and thank you once again for having us.
No more fear. Are we like cheating a little bit that tech can be for everyone? You can be digital and be cool, and be nice, and be a great doctor, and be a great policymaker. So tech is for everyone, and the PS just made a call for action that we need to join hands. No one should be left behind. So we would like to have this opportunity to invite our guest of honor, representing the Minister of Health, who could not make it, the PS from the Ministry of Health is here with us and would like to call up him for his remarks. Thank you so much. Thank you.
Thank you very much. Your Excellency Ambassador of Japan, dear PS, DGRBC, Executive Secretary, National Commission for Science and Technology, representatives of UN agencies and other international local NGOs here present, dear partners, stakeholders, Director Generals of hospitals, researchers, ladies and gentlemen, good morning. Good afternoon for those attending online where they are. We are very happy to be gathering today at this occasion, and we are very much appreciative for your commitment and time to this symposium. I'd want to start by appreciating the preparation committee for the work they have done from the very beginning up to the choice of the topic. I don't know whether you have seen that the topic was very timely. When we are talking of innovation, innovative practice for better health, I think we can never have such good topic other than having it after the pandemic has shown us that we need to be more innovative in what we do. We need more innovations to respond to emerging crises into the health sector, and this can only be done if we all put our efforts together towards new practice that can innovate. If you look at from the last 2 decades, our country has achieved significant milestones towards strengthening health systems in terms of controlling most killing diseases, including HIV, TB, malaria, as well as reducing maternal and child mortality, but also addressing the burden of non-communicable disease and engaging the community towards universal health coverage. All along, there's tangible achievement. Health system is boosted by existing and evolving health sector digital solutions that's supported to track the trend and employ innovation technologies and innovative through evidence generated from various researches. Furthermore, the remaining gap to be closed need a robust health digital solution that are helping to capture and generate data to inform ongoing and new innovations. Evidence-based practice should be at the center of each process of the service delivery across all levels of healthcare system. Nonetheless, COVID-19 has exposed our service delivery and impacted our systems that were already fragile. However, this showcased the benefit of enhancing the data use, creating stronger and opened rooms for more innovations in data science to facilitate timely data capture and use. As we are in the phase of recovering and setting the ground for the other epidemic preparedness, we should not lose the momentum, the knowledge and skills we gained. Rather, we should leverage these tools, knowledge and skills to address other diseases and continue to improve our health outcomes. In line with Rwanda's digitalization plan, the Ministry of Health is guiding the implementation towards a full digitalized health sector. It is in this time to recall it is a high time now to call for collaboration and multi-sectoral engagement to sustain these gains, involving more community engagement to track even more community records in epidemic response and preparedness. Rwanda was the best example of this when thinking about community health workers' role in the home-based care, surveillance, and contact tracing. This symposium is another occasion together all as actors, students, and researchers, data scientists from different partners and stakeholders to actively support the digitalization pathway. I'm looking forward to having successful consultations during these 2 consecutive days and bringing out more experience sharing and connections toward optimizing data innovation and science in improving service delivery into the health sector. With this note, I declare this session, this second edition of the Health and Research Policy Symposium to be officially opened, and I wish you successful deliberations. Thank you.
Another big hand of applause. Aren't you happy we're not going back? This is officially opened, and we are going to have a great session of actually 2 days. And I like giving stories, so I'm gonna give you another story. I've ever been in a restaurant, and they handed me this big menu. It's like a book. And I'm just so hungry, and I don't know what to eat, and they're giving me this book to go through and pick one meal that I want. And you actually want to see if there's anyone you can call upon and tell them, like, give me a recommendation, I just want to eat. But sometimes you don't get to get those people. So possibly someone is sitting in this room thinking, what is there for me for the next 2 days? What do I have on this menu table? How am I going to choose? What is the breakfast and what is coming for lunch? What is coming for dinner? So we've actually saved that for those other restaurants. And here we have a dedicated person who is going to take us through the menu and tell us what to expect for these upcoming 2 days. He's none rather than Dr. Jean-Claude Ngabonziza. He is the chair of the scientific committee and the division manager of research, innovation, and data science at RBC. Can we appreciate him as he's walking to the stage? Thank you.
Thank you, MC, and thank you all for joining us in this symposium, which we really expect to see researchers, policymakers, academicians, all together exchanging what is going on in digitalization, in innovative research, to make sure the implementation is more accelerated. So what do we have by taking you through the menu? One thing is that our menu is so delicious and will be enjoyable for all who really want our health system to go digital, to move from, I think we have gone far and we still have some steps, and that is now and on. So we have 2 days, the symposium. The first day, we mostly focus on digital solution for better health. That is today. And tomorrow, we have innovative research practice for better health. So those are the 2 main components of the symposium. And within each of the 2 components, we have very good sessions where we have speakers with recent knowledge, skills in digital solution for better health. We have the keynote speaker for the both 2 days. One, we focus on digital health solution in infectious disease control. And the second will be more on strategies, more on research innovation methods in public health and environment. So during the 2 days as well, we have a very interactive session of panel discussion where we be discussing on different approach, including the strategy to increase the use of digital solution to improve health. That is today. Then the second day, we also have a very interactive panel session that we discuss on promoting innovative practice for better health. Those are part of the panel discussion of the 2 days. Besides the panel discussion and the speakers of today, we have the abstract presentation. We have selected the best abstracts in the 2 areas, which will be running in parallel sessions. One will be running in this room, and another session will be running upstairs. And the best abstract will be presented half of in the afternoon, and half of the selected abstract will be running here, 5, and the other 5 in the other upstairs room named mezzanine room. It's upstairs. So what do we expect from this symposium? We have 4 main objectives. One, this symposium is made to connect health research community in Rwanda. And that is what we really hope will be achieved by this symposium. The second is to promote grassroots research through this discussion. The third will be promote innovation for quality healthcare. And fourth, discuss the contribution of research to the national development. The 4 objectives, which we hope will be covered during our symposium, and we'll be building one goal, make the research funding into implementation, focusing mainly day 1, digital solution for health, and day 2, innovative research for better health. Thank you.
Are you now ready for your order? Was the menu right? So, great. So the order is now ready, and we're going to start with the very delicious food meal that we said, as we said before. And our first session is going to be led by Associate Professor Richard Lester, who is an infectious disease specialist at Vancouver General Hospital and an associate professor in global health at the University of British Columbia, and a director of Neglected Global Disease Initiative. He's also a co-founder and executive director of the World Health Technology, supporting and promoting access to virtual health services through mobile and computer-based applications. Dr. Lester completed his research fellowship in HIV in Kenya and at the University of Minnesota and the University of Nairobi, a collaborative research, where he initiated development of innovative mobile phone, which was called mHealth, a service that was demonstrated in a landmark trial. WellTel Kenya was published in Lancet 2010 to improve outcomes funded by the US, the CDC, and President's Emergence Plan for AIDS Relief, PEPFAR. His program's research to action and patient self-management approach has been published in top-tier medical journals, including the Lancet, the New England Medical Journal, and Lester also has consulted on mHealth innovations with World Health Organization for HIV, TB, tobacco control. Dr. Lester received the 2020 Digital Health Canada Clinton Health Initiative Access with a Clinical Innovator Award. That person is not in Canada. That person is in this room and is going to talk to us. So, as the hostess will say in a plane, fasten your seatbelt and follow. Let's have a hand of applause as we welcome Professor Lester to talk to us.
Thank you. I think it's working, the mic. It's a very pleasure to be here. Thank you to the organizers, the honorable ministers of health representatives that are here, the Director General of the Rwanda Biomedical Center, all the professors, teachers, implementers, and hopefully students that are listening in today. My journey started as a student, actually, as most of us have, so it's a real journey to start learning and implementing. Very much a pleasure to be here. Now, I'm not sure how my slides, somebody has them to start them. I'll just say advance, please. Thank you very much. So this is actually, in my welcome slide, is a picture of near Vancouver in British Columbia in Canada in the center, but also the beautiful country of Rwanda and city of Kigali, where I really love to be, so it's an honor to be here once again. And I get to speak I'm an infectious disease physician as well as a researcher and innovator in this space. So I'm going to talk to you a bit about my story, but I'm really here to listen to this fantastic symposium. Rwanda's been a place that's really taking leadership in the field and moving forward in digitalization of healthcare, and I'm proud to be here. So next slide, please. One of the things we did at the beginning of the pandemic, we actually got funding from the Canadian Institute for Health Research and Grand Challenges Canada to initiate some of the previous work we did, but we thought we better do a rapid landscape. What kind of digital technologies are available at the beginning of the pandemic? This was in March of 2020. And we did a rapid review, and you're welcome to look at it, and we focused actually on the countries as examples of Rwanda, Kenya, the UK and Canada where we're working, but I can tell you it's already thankfully out of date, and we're scrambling to do a new update because there's so many new technologies coming on the scene and the evidence is growing, and we really had to divide it into prevention, diagnostics, and treatment because really digitalization is crossing the full spectrum. Next, please. Tell you where my story started. The other pandemic many of you have had the opportunity to work, and thankfully we've seen a lot of gains, is the HIV Aids Pandemic. And I was doing my postdoctoral fellowship in Kenya, as mentioned. We thought I was going to actually work on vaccine work, and we thought they were rolling out antiretroviral treatment for the first time through the PEPFAR program, then eventually Global Fund and others. But people were very worried about adherence, medication adherence. They thought if people didn't take them right in Africa, because they're often being paid for in the US and others, that the adherence would be poor, lead to drug resistance and problems. So there was a lot of concern, but as we see, which is very nice, and this is an old slide, but I like to put it up from the early days, The HIV pandemic, the dark bars there on the bottom represent the majority in resource-limited settings, lower middle-income countries. And at the same time, though, we did start to see antiretrovirals scaling up where the virus was circulating the most. But there was another pandemic, I'd like to say, or epidemic happening in the world at the same time on the right that leads to a possible solution, and that was the uptake of mobile phones. And you'll see that the dark bars on the bottom, the largest uptake of mobile phones in the world rapidly was actually in lower middle income countries. So we saw a match between innovation, technology, and one of the health crises of the day. And that provided an opportunity. And really, innovation is about matching what are the opportunities of the tools we can use, how we can use them to solve the problems of today. Next slide, please. Advance one more, please. So good mentorship is really important in science and research. And at the University of Nairobi, UNITED, and all of our colleagues, I had international researchers from around the world that were leaders in clinical trials and gave a lot of good advice, how to register your trial, how to design a randomized controlled trial. So we actually organized, and I led one of the first text messaging trials to use mobile phones to support HIV care and treatment to improve adherence and outcomes. And due to good mentorship and the opportunity to conduct a good study, we were able to demonstrate that a simple text message, and this came from a lot of groundwork too. We got all of our patients together, frontline providers together, and said, how do we use mobile phones to improve healthcare? And we came up with something very simple. It was texting. For those of you, I know Swahili is spoken a bit in Rwanda. We texted Mambo once a week. And they responded, Sawa, I'm okay, or Shida, there's a problem. And that just allowed that people who had seen the doctor, got an HIV diagnosis, got 3 drugs they're supposed to take, and then leave, the opportunity to stay in touch with their problems as they evolved over time. And that simple being in touch was able to lead to improvements in medication adherence over 1 year, improvements of suppression of viral load, and therefore we know that that saves lives, and it also reduces transmission to others, simply by being in touch through their mobile phone. Next slide, please. This research, of course, has expanded broadly. I took a right turn in my research from the lab to mobile and digital technology early on. Through a lot of international partnerships, we've conducted over 7 or 8 randomized clinical trials, reviews. When we started to shift into implementation research, because we realized too, the studies themselves are core, but we also need to turn that into action, which is, I think, some of what we're seeing today and the motivation behind meetings like this. And then now what's really exciting, and I'll talk a little bit about, is the next level of science, which is data science, really providing us new opportunities through powerful computing to learn things that we were never able to do before. Next slide, please. So the WellTel solution, which we came up with, now called WellTel, is very simple still at its core. It's really about texting to people, patients, to check in how they're doing, allowing them to respond whether they're okay or they have an issue and need follow-up. We use open language formats, keep it very simple, because at the end of the day, it's about who you reach. And we realized working the HIV pandemic affected everybody. It wasn't just the rich, those who have. It was all ages. The oldest person we enrolled in our trial in Kenya was an 81-year-old Maasai woman in a very rural area who didn't speak any English, and her grandson used to text back, "Grandma's okay or not." Didn't even know her diagnosis, but was still acting on her behalf, led to a better outcome. So keeping the technology simple to reach is very important and appropriate. But at the same time, this means we're collecting, as we learn to scale and we build the technology, how do we offer this at scale? It collects a lot of very valuable new information that we might be able to use to improve our health systems. Next slide, please. So fast forward a few pandemics, and unfortunately we've been through a few. We've had from HIV, TB is ongoing around the world. We have many emerging. The H1N1 pandemic thankfully wasn't as bad, but then came the coronavirus 19. And since we had a mobile method already of following patients, and we were working on some HIV programs at the WEACT Clinic for Hope in Rwanda, where they were successfully following some vulnerable patients to stay in HIV care, especially women and families. We thought, and speaking with the Rwanda leaders, how do we use a technology that can help monitor people from the first wave of the pandemic? People thought maybe we need treatment centers to keep everybody who has coronavirus in a treatment center. And we realized, not just in Rwanda, around the world, that was very difficult, too many people getting it, and many weren't sick enough yet to require it, so they would need home care. But how do you monitor home care at scale when people are in urban areas, rural areas, and at such a mass scale at the time? So speaking with then the Director General of the Rwanda Biomedical Center, we thought, well, let's scale this up quickly and use it as a way to reach out and follow patients through home-based care, and that included contacts as well. So in the first wave, we actually deployed very quickly. We did, I think it was a Zoom call for an hour of training across the country with the command post from the center. And we really started rolling it out very quickly and a little bit learning as we go. Instead of weekly check-ins, of course, with coronavirus home-based care, we thought, well, let's make them daily check-ins. We'll ask a bit about symptoms as well for 2 weeks during their home isolation period. And if they have any problems, we can help sort them out. And if they need transfer to a treatment center, that can be arranged as well. So through the waves of the pandemic, we continue to work with the Rwanda Biomedical Center to make improvements on the technology, started to build in some contact tracing communication components so that contacts could be easily communicated with as well in case they develop symptoms or needed testing. And next slide, please. So very interesting, and I'm going to talk a bit more about the science today and what can we learn from the data from this, because we can always do randomized trials, and they're one of the most rigorous way to test an intervention against other controls. But there's also a lot we can learn from the experience itself. And next slide, please. And in fact, we went back recently and looked all the way back through some of our HIV trials, and we found that just by the texting pattern, how often they text in, when they text in, we could actually predict with quite discrepancy whether they were going to have a suppressed viral load at the end of a year or not. So instead of waiting for a viral load at the end of a year to find out people have fallen out of care, they've failed, maybe they've gotten sick, maybe they've transmitted the virus to others, we can probably detect this quite early just by being in touch looking at the texting pattern. Next slide, please. Further to that, and this is where science gets really exciting, even though we have a very basic intervention that reaches people. And we included, actually, in Rwanda, one of the innovations was families. So we thought, well, maybe some households just had one member with a phone representing the entire family who might get sick at different rates. So we thought of ways to use proxies and shared phones within the system to ensure the reach. But all of that communication was captured. So now we're partnering with some of our colleagues that use natural language processing over the last couple of years to look at what are the conversations about, what are the issues that patients are coming up or the people we're following coming up and discussing with their healthcare provider. What can we learn from that data? And I can tell you I did the same thing from our original trials, but I had a PhD student spend about 6 months going through tens of thousands of conversations, manually categorizing them. But with the computing tools we have today, we can do this very rapidly and in real time using machine learning, AI type, natural language processing, etc. Next slide, please. So overall in Rwanda, we continued to work with the Rwanda Biomedical Center and the teams around the country to scale up the program to support people with COVID on their home-based care program, which has been a very successful program. I've seen outcomes of research published on the home-based care program doing very well. Very safe, actually. I think Rwanda was able to monitor hundreds of thousands of patients at home without really losing anybody in the community, which is remarkable. And you can see that the numbers of conversations, at this point there were 37,000 conversations that were happening with people who were being monitored from their homes. Next slide, please. We started to do topic classification too, and looking at this data, some of it manual. We use supervised learning to help train the algorithms, and some of it is discovery data using NLP. And we can see that the conversations when you use open language, we're very used to structured data because we like structured data because we get exactly the data we want. But what the problem with structured data is we get the data we want, we don't get the full data that could be there. When you ask someone how they're doing, they can report on anything. They can report on vaccine-related questions. They can report on symptoms when they finish quarantine. They can talk about, I'll show you some examples, other things that we might not have even thought of. So it gives us new data, but I think it actually gives us better and more true data. Next slide, please. These are actually some real examples from the research of some of the texts of patients who are being monitored in the home-based care program in Rwanda. And you can see it's not just I have symptoms or I don't have symptoms or I lost my smell, but good morning, I have a mild headache. Can I take paracetamol? People don't know some of these questions, and a lot of the fear, the anxiety is about not knowing what to do. Also taking medicines for malaria. People, of course, it's not only coronavirus, but also some questions you see that about their children. I'm fine, but my child is having is missing school, or I can't go to work. All of this type of information is real world, and if we're going to improve quality health systems, we need to work with the real world. Next slide, please. And we have some much more fancy visualization tools that are coming. I'm not able to share today, but these are some messages too. For instance, the incoming message, I'm homesick, but why? Nobody has reached me. I'm going to die of hunger. Another one, the problem I have, I'm hungry with my family and can't go to work these days. So in managing, and this isn't just in Rwanda, in fact, I can tell you this happens in Canada, it happens everywhere in the world. People staying at home for isolation are facing all kinds of issues. And if we want them to adhere to those issues, we need to address their concerns. And obviously, it's not possible to stay home for 2 weeks and not eat if you don't have food. So I think there's UNICEF is one of the partners in the room. This type of data that we can provide to look after children, to look after families, to look after hungry, the social determinants are all equally important in managing individuals in today's world. Next slide, please. This is just another example of some of the data overlap we had people talking about. As it was interesting over time, early in the pandemic, vaccines weren't even on the scene yet. But of course, once vaccines became available, the conversations really started to change where people were asking about symptoms, but also asking about where they can get vaccines. Next slide, please. And then I think the Honorable Permanent Secretary from the Ministry was mentioning about contact tracing too with TB, for instance. We'll be working with the TB department on management of TB and contacts, but with coronavirus too, how does contact tracing work? So we know that communicating with individuals who might have an infection is one thing, but those are also people who have a valuable knowledge that you can't get from anyone else about who they may have been in contact with, where their path is. So it includes support for isolation, again, because if they're meant to stay home, they need support to do that effectively, but also observation for symptoms, offering of new treatments. If you have a way to communicate with the cohort rapidly, instantly, we can update them about new changes as well. There's new treatments available, there's new vaccines available. That information can be directly targeted very quickly. Next slide, please. Just another example of some of the dashboard of visualization we're working with, and I can happily say the last time I was here in Rwanda in November, I met with the director of the African Center for Excellence in Data Science at the University of Rwanda, and we're really proud to be starting to build some partnerships there to understand better how do we look at this type of data. Next slide, please. And the last point I want to discuss as we make our way and plod the agenda forward in Rwanda and elsewhere is healthcare affects almost every person at some point in their life between birth and death, and most of us multiple times. So unless we're developing tools that reach everybody, we're not doing the full job. And we know that's part of the UN Sustainable Development Goals, but it's what we all know about healthcare. If you focus on the 70%, the 80%, the 90% are actually missing a very significant portion of the population, often most vulnerable, and often the ones that drive the indicators the most. If you focused on the best 70%, you'll get even 80%. You'll move the dial more, focusing on the 20% that are more left behind. So as we do digitalization, we need to think throughout this process, is the intervention we're having reaching the people who need it the most? Next slide, please. To that, one of the things we really learned from our collaboration in Rwanda was about language and language equity. As we know, in the first cases of COVID-19 in Rwanda often came from people, international travelers who spoke English. And we saw that in the conversations. Most of them were in English. But very quickly, it became a community transmission, and the primary languages were French and Kinyarwanda. And we had to quickly adapt. That was easily, because it uses open format templates. That was able to be done immediately. And following patients in Kinyarwanda, there's actually research studies that show that people that get healthcare in their own language, their first language, are more likely to have good outcomes than people who get it in a second language. So I think in digitalization going forward, we don't want this to be an afterthought. We need to think about language-appropriate digital tools during their development process. We can't just wait until they're implemented in English or in other languages and then translate them. We'll be just behind. So if we start thinking about that now, one of our collaborators in the NLP at the University of British Columbia did a recent study of over 1 billion data points of Twitter around the world, evaluating those who were discussing COVID, and it was in over 100 languages. Kinyarwandan was one of them. And so we're partnering there to start to look at how do we actually start to look at what are the best languages, including indigenous languages. There's more than 6,000 languages spoken in the world. So we need to make sure that we cover in the best way all of those languages we engage in digitalization forward. Next slide, please. Just in closing, I'm going to talk about, again, it's a pleasure to be here in Rwanda. My two favorite coffee shops in the world. One is over on the left in Kigali. It's Questions Coffee. I don't know if any of you have been there. Great place to do some work, catch up. And then in Vancouver is one of my other ones. It's an Italian coffee shop, makes good coffee as well. So the two cities look a little bit similar. But I think what we find is there's more commonalities around the world as we share our research than there are differences. So next slide, please. So just a few points, and these are my own, but I'll be very here to learn from others. Number one is use digital health to address clear health goals. So there's a lot of technology for technology's sake. It sounds good, there's salesmanship, but at the end of the day, our project started with how do we help people with HIV infection stay on their medication so they have better outcomes? And then we came up and we started from the ground up. How do we do that? Turned out that same method of saying, how are you, checking in by text, worked in Kenya, but we repeated the study among vulnerable women with addictions and with HIV infection in Vancouver, Canada, and found it also helped them be adherent and suppressed viral load. So just by checking in. So whatever the goal is, whether it's prevention, diagnosis, treatment, I think we really start with the problem and think, how do we use the technology to help solve that problem? And it should be evidence-based. We work in the era of evidence-based medicine. There's lots of good scientists, lots of good opportunities for partnerships with universities to really make sure that what we're doing is data-driven, data-based. And consider both, this is the big one for me, and all my work at the WHO meetings and so on, but everywhere, is consider both the future and today. The future is very exciting. A lot of the people working in technology are they're very smart, they're very excited, they want to use this technology to its maximum. And that's good, we should continue to do that. We want to be part of the future, but we also have to use what works today. So we're not doing catch up. We're not yet doing self-driving cars. You still have to drive regular cars today. Same with healthcare and digital solutions. The reason we use SMS text is because less than 50% of people in the country had internet access. So if you use a tool that doesn't reach 50%, and which 50%, it's just not the right tool for today. And we can still do high-tech analytics, NLP, machine learning on the data from that. So the real trick, I think, is finding a good balance between high technology and what really meets people's needs today so we have the largest impact. And then the other emerging benefits of data science, I think I don't need to convince people in this room. The new data, these new tools generate way more data than we could ever manage manually. But thankfully, these tools also provide abilities to do computing at large, big data levels to get real data real time. So very exciting times for that. And then the bottom last one, keep health equity at its core. I can't say this enough. If it doesn't reach everyone, think about, if it reaches 90%, think about, well, what do we do with the remaining 10%? How are we using our technologies to make sure that everyone is reached? And I think that's part of sustainability as well. And I think a lot of the lack of scale or adoption of digital health, as much as we had all hoped it would be over the last decade, is actually because some of the technologies got a bit too far ahead of themselves, focused a little bit too much on the haves, instead of this balance of making sure we follow, healthcare is for everyone. That's just an extra slide. We can even go back one and just leave it there. And I'd like to say thank you very, very much. Working in Rwanda has been one of the, honestly, best experiences I've ever had in my career in terms of I've worked in places that have good private sector, I've worked in places with good public sector, and good academics, and Rwanda really seems to have all of those ingredients and a real agenda to move things forward to be a leader in this field. So it's a pleasure to be here. Thank you.
Thank you so much, Prof, for the insight and actually opening up with those great findings from both a collaborative research, something that can actually be found in two countries with a very different perspective and very different participants. So thank you so much for taking us through that. We're going to go to trying to catch up with time, but we're going to go to the next speaker. And it's a whole story of how our next speaker actually, the journey that he took in this field of digital health. Before I actually introduce his name, he's someone who joined the Ministry of Health in 2010 as an e-health expert. He was hired to manage and strengthen the e-health systems. So doing so, being an e-health expert, he hugely got skills in the development and implementing of e-health tools and supporting end users. Only 2 years after, he became an IT coordinator for the community health information systems, mainly leading community systems, task force, and implementing partners. Regular briefing of updates on community health systems, supervise and follow up the training course for community health workers by ensuring a high-level hands-on skills acquisition and brief software training program. He also observed usage pattern and documenting challenges encountered by end users. So from 2015 and 2021, he was appointed to coordinate the health sector digitalization under the Rwanda Medical Center, where he was leading a national technical team in charge of health management information systems at planning and implementation levels. He also led on design, development, and deployment of electronic medical records at national level and other e-health solutions, all health sector levels. He completed his Master's of Science, Information and Technology at Madras University. He is none rather than Mr. Jean-Baptiste Byiringiro, who is the Chief Digital Officer at the Ministry of Health. A big round of applause as we welcome him.
Good morning. Again, this is a pleasure to have you all, and it's an honor for me to be in front of you just to share the health sector digital transformation agenda, as well as giving you the progress and where we've been working and what we've been able to sort out so far. So I'm going to just to bring you through with a couple of slides. I'm going to talk mainly to give you an insight of the health sector digital transformation blueprint, as well as giving you the progress that we have made so far. Next. So this slide it's about the health sector structure, but for IT, it means a lot because it shows where when you implement any digital solution, where you put much focus. So as you can see, the last three layers, it's where there is high burden. It's where we are receiving a lot of patients. And when you are to deploy any digital solution, as you can see, you put much focus there. Next one. Next. So the digital solutions has been so far an enabler to achieve global and national targets. When you talk about the universal health coverage, as well as SDG, especially on its third goals, they are all talks about the improving the health care. So as you can see, the global challenge now is how can we reach our patient and make sure that they are receiving the health, the digital solution to improve their health care, as well as giving healthcare services to them. So in a couple of 10 years, the Ministry of Health has put in place several digital solutions, of course, to respond on above targets or visions. So we managed to implement different systems, including integrated routine reporting health management information system, electronic medical records, system for managing logistics, community health workers information systems, laboratory information systems, different system integrated in one for disease surveillance, including the one for COVID, as well as different system for blood management of blood donors, blood distribution, as well as pharmacovigilance as part of this. Next. So maybe to talk a little bit on journey. So this is actually the current scenario in our health facilities, where you are having a lot of mix-up of paper, digital, and you can feel how this is a high burden for clinician to fill out paper and digital. So this is actually the big challenge. And we thought about it when we did our digital transformation blueprint. Next, please. And this scenario, next. And this scenario resulted to have this disconnected patient records. So silos system, as I have presented before, made this disconnection of the patient records. So where actually it's quite difficult for us to make sure that we are following the patient from the first consultation up to discharge within the sector. So This is very important because when you are treating a patient, you need to make sure that we manage the continuum of care. And as such scenario, there is a bit of repeating same information, same test, same bill. And from this, actually two key challenges, we said that we need actually to think about beyond this and build our digital in a way that we respond on two key challenges. Next. Now I'm going to talk about the digital transformation roadmap, the one that you have developed in last couple of 2 years, just to respond on above challenges. Next. So this is a summary of digital transformation blueprint that we have developed. It is composed with 3 big phases. So the bottom one is a foundation. Is actually the way we have started with, and it is mainly to build an enabler of the rest of phases. So it is mainly for establishing an interoperability framework, make sure that our different systems are able to talk to each other, then establishing the health information exchange standard, make sure that our different systems are talking to each other and they are well harmonized. Managing different integrations, focusing on electronic medical records because, as you have seen, there is the big gap in terms of management of the patient records. And we had also focused on community health information system within 18 months from last year. So this is a foundation, and if we manage to success with this, the last one will be easier. Next. So this is actually the way we want to go. So we want to go. We want to have one patient, one record. So to make this possible, there is a lot of behind because be able to have one patient, you need to have the unique patient ID. And this unique patient ID, it has to be the same across the sector, being public, being private. So also, we want to put much focus on the patient engagement as well because our traditional electronic medical record was mainly just to manage the patient who is attending facility. And now we are thinking beyond that, where the patient can even ask an online service. We can do remote consultation, where the patient can pull out his information from lab, where the patient can talk with his doctor, where the patient being at home can do some self-screening, maybe especially for NCD's patient. So this architecture of having one patient, one record, it's going to contribute and address all those challenges I talked about, having scattered information, silos, and so on. Next. So this is the journey for phase 1 for 8 months. So we have developed the key project priorities that will enable us to have the output, which is one record, one one patient, one record. And we have set out a couple of 5 key activities. One is building the infrastructure, being health cloud, equipping hospitals with the IT equipments, being community health workers devices, and then we have managed to develop the standard, the interoperability standard. As you know, having one record, it means that we will be able to track the patient across our health facilities. And wherever you'll be seeking service, we'll be having your clinical background. So this network will be feasible through a middleware, which is Health Information Exchange, that will manage those kind of information exchange within our health ecosystem. So those standards, actually, for example, when you are sharing medical records, being consultation, being clinical images, it has to fulfill a certain global standard, and our system has to be able to exchange those information because they have those, they are meeting those, they are compliant with those standards. And then an HIE is going to manage or to help on management and channeling all those information. And also we have an enhancement of our existing electronic medical records. We have doctors here at different hospitals. They know how much the existing system is having some gaps. Now we are working on a strong system and a comprehensive one. Make sure that when you arrive in a hospital, from the entrance up to discharge, they no longer use paper. So they track you from the entrance up to discharge, and then this HIE will facilitate the roaming. So after the discharge, you may go to another health facilities, and then they can have your clinical information, your clinical background. So finally, we also are working on community health workers information, which is actually a big one, because the recent situation is that the community health workers can carry even more than 5 registers. And each and every register, you can feel how it is very cost, and it's a burden for community health workers to fill out all of those registers. So we thought about to build a simplified tool to facilitate all records for community health workers. Next. So this is actually the architecture that summarized all things I talked to you. So let's try to use a pointer here. No. So we have basically 3 big layers. We have the top, middle, and bottom. So the top one, actually, they are mostly the HIE components, which are mostly going to help in standardizing all our medical information. We have the one CR, it's a client registry. We have facility registry. We have a terminology one. We have health worker registry. We have shared health record. And in the middle, this is the National Health Service bus, which we channel all of those information. Below, we have the patient level applications, being community, an EMR, any system that we'll be using for just at patient level. So this ecosystem, it will contribute to develop, to give a central data whereby we'll be having a warehouse just for the benefit of having national statistics, as well as contribute on different researches. Because now the scenario is that when you want the information from one system, it requires you to go into a different system and pull out information you are looking for. So we are targeting to have a warehouse whereby whoever has or authorized to have this information will be able to pull information as he's looking for. So those the app registries, they are very useful because to be able to have one patient, one record, of course we need to have the client registry, which will be connected to a single truth of our citizen identification, which is the National Population Registry, to make sure that we have one citizen, one patient identified or verified from National Population Registry. Of course, facility registry is very important because now each and every system currently it has the facility list. So we don't have national master facility list whereby, for example, if you want to, if there is a new facility, it requires you to go into different system and then update each and every system. And then that master facility list will enable us to create a facility once, and then to get replicated to different systems connected to this ecosystem. So I'm going to take a few minutes just to share with you the progress that we've been able to do so far on that roadmap. Next. So for health data interoperability standard, we have already closed this activity. So we have a national guiding document, and now we are trying to implement it and make sure that whatever we are implementing we are in compliance with that guiding document. So any system that will be able to connect to this electronic health information exchange, it has to meet those standards. Second, health information exchange, we are almost done because we are at 75% of it. In next 2 months, we'll be done. And enhanced electronic medical records, we are at 20%. And then the rest two, we are at starting level. We are at starting stage of the list of 2 activities. So I think that's all I have prepared for you. Thank you very much.
Thank you so much. I would like to see some people who are working in the medical field. Do we have like doctors, nurses, the people who are working? By show of hands, can we just see those people? Thank you so much. So, can you imagine if you're in a consultation room and you're receiving this patient coming, and you can actually trace the record from their consultation they have done at a hospital in Karongi? How that would be easy. It's going to save us so much time, This patient that are telling us, yuko inzoka yamufatiye mu kuguru, ikazamuka, igafata mu itako, ikagera ikajya mu mugongo. There will be a doctor who have already translated those information into a medically easy to learn and easy to interpret. Imagine what our country is actually doing. And I've tried to look on Twitter. You guys are not tweeting. How can we share that information to other people? That is not an information we should keep on ourselves. Thank you so much. And we will thank the people from the Ministry of Health who are actually doing everything they can to make sure that our health system is fully digital. So we're running out of time. Oh. So the next speakers, we need to get on the agenda. Thank you so much. So who is going to speak to us next? We're going to now dissect more on the role of digital solutions in a pandemic preparedness and response. I'm sure most of us can actually come and talk something about this. However, we've got an expert who is a PhD candidate, who is also a health scientific innovation analyst at RBC. He's a senior statistician and data scientist with a strong knowledge in statistical methods, data handling, and data analysis. He has an extensive knowledge in designing prototype of health information systems, evidence-based strategy, planning, and operationalizations. He's also a researcher in statistics methods, focusing on modeling infection diseases, concentrating on spatial and spatio-temporal models. Mohamed Semakula holds a PhD, holds a bachelor's degree in applied statistics from the University of Rwanda, a master's degree in statistics and biostatistics from the Science Department of Mathematics and Statistics at the University of Hasselt in Belgium. He is a PhD candidate in he's a PhD candidate in a joint PhD program in statistics at the Center of Statistics and Data Institute in Hasselt, Belgium program. He is an expert, and he is not done yet. He's doing more in this field. Let's appreciate him, as he's going to tell us about how we should get prepared, probably for the next pandemic. Who knows?
Thank you very much for the good introduction. It's my pleasure to be in front of you, just discussing a topic that everyone can also discuss, because the role of digital in pandemic, I think everyone in this room can say something about it. But in this occasion, I just want to try to give you our experience during COVID-19. As you know, that's pandemic. When it came in, everything was new. No one has tools. No one was prepared as it was supposed to be for other diseases that have been there for long. So therefore, I'll just go through for how we did in terms of managing and how digital health contributed to control the COVID pandemic here in Rwanda. And I'm also glad that I'm following Batista, who was presenting the plan. But among those plans, there are some of things that we are pushed to do during the pandemic, and it works. Maybe it can also guide for fasting some of other strategies that we are forecasting. Okay. Thank you very much. Pandemic preparedness and response requires two main things. If you look generally, you will need, most importantly, reliable and timely data. That is something that's very important. Without having information, it's very difficult to manage, even to take a decision on how controlling epidemic, because you need to understand the transmissibility of that disease. You need to understand the burden of that disease, and you need also to know the effectiveness of your intervention and whatever you're going to take as a decision. So sometimes people look other things, but the backbone of everything should be reliable and timely data if you want to cope with a pandemic. The second important thing was on decision. The decisions that people are taking that are relying on evidence are a key success of coping with a pandemic. The pandemic requires evidence-based, not subjective, not ideas, but you need to have a fact and a tangible fact. That's what Rwanda did. And that's why we managed to gain the success that we are having so far. One of the biggest decisions, there is a group of experts from Harvard University, Prof. Mark, actually he's our collaborator also. They conducted a study in 2017, and they published a paper about managing pandemic in 2017. And here are two elements that they presented in that paper. One was, there are several decisions that people have to make during the pandemic, but all those decisions can be summarized into two elements. One, you need to define the overall scale of your response. It sounds like simple, but not really, because to decide about the scale of pandemic, of your response, you need to know, to have some quantitative information about the transmissibility of that disease. You have to have information about the burden of that disease. If a country like Rwanda will decided to lock down their country because of this pandemic, you can imagine the impact that's going to cause to the country on other sectors. So it's important and relevant to know what is the magnitude of that disease so that you can take a decision. Another important element that they figured out was the countermeasures. Something like COVID that we had, there was no cure at the time. We didn't have even information of what is going to happen in terms of transmissibility. There was no study, there was no other things. Everything we were relying on models, trying to see the few cases that we have and try to identify the rate of transmission and try to have an idea on how it looks. And it was even bad because it has never happened in anywhere. It's happened globally at once at the same time. So there was no reference. And this is also very important. You need to know, do you have a vaccine in place? But if you don't have treatment, you don't have vaccine, then that's when we push you to go to several other measures that might be even more serious and affecting many people in order to control the spread. But the success of controlling will depend on implementation of those measures that people have taken. If the implementation is not flawed as it is, most likely the success will not be there. But success will depend on the implementation of those measures. And this is a systematic view of the public health decision highlighted by Prof. Mark in their publication in 2017. They figured out 4 main elements that I want all of you to think about. On the bottom, there is surveillance input. In other words, it is data. The data are the foundation of everything in terms of dealing with pandemic. And then in data, I don't want to go through each type of data, but some of them you can see, like you need to know the confirmed case, you need to know the syndrome surveillance, you need to know laboratory. I mean, a lot of the type of information that you need to help you to get some evidence. But there is a second component, which sometimes people, they don't take it, they don't give it the weight that it should have, which is interpretive tool. Having data, it's one thing, but using those information, it is another thing. Currently, we are producing an amount of data that are not being used. We find that we're using only something like 10% of the information that we are generating every day. And this is obvious because every second we are generating data. Every second we are storing data. And those data cannot be used efficiently unless you have made a strong component on data processing, on data using, so that those information can be useful in terms of taking decision. And that's where some of the emerging technologies are coming in I had Professor Rich talking about NLP and machine learning and other technologies that are coming to help people to use efficiently those type of information that we are generating on their basis. Another component, once the second component is covered, then it will help us to do some statistical models, some analysis, some estimation, whatever you will do. But the aim is getting evidence, and that evidence, it will give the decision makers, the public health experts, to take a decision that can help to save the people, the life of people, using those evidence. So it's very important that the first two components need to be strengthened in order to have the right decision, since the decisions are based on the evidence. We are generating a lot of data, but also those data has to be processed, has to be used so that evidence can be availed, and then it can lead to decisions that are accurate. Next. This is our case for Rwanda. Our case, this is how it was structured during COVID. And this is, I believe, this is how it's still. So the first thing, we put on foundation the data. We had laboratory data that we get on real time, outbreak investigation, contact tracing, treatment centers, and so on. Then on the second part, we need to come up with a way of processing, which is on red, visualization, estimation, and so on. But currently, we are facing issue of something like data retrieval, accessing some of data, because we are having a huge amount of data, and using them, it's became a little bit difficult due to that amount, which means there's also a need of working on environment that will help people to use the information as it is, rather than storing only the information. And then this third component was evidence, which was provided by that team, and that's one led to the decisions that our readers were taking every day in order to manage. You could see the red paper coming up with decisions and so on through those processes. That was the channel. It has never been subjective, but it was a processes basing on the data use until the decision is come out that we need to adhere as Rwanda in order to cope with the spread of disease. So, now, there are elements that we had to take as into account in order to make that plan more implementable. We needed to establish a comprehensive structure to manage COVID, which the government did, the command post and others. And then there was also some information, some decisions that had to be made in order to cope with COVID. That was transforming our laboratory and flow in order to adapt the situation that we had. Pre-COVID, the way we were working, it was a little bit different from during the pandemic. So there was a lot of change that's required. And then adaptive strategies, depending on the analysis and data are available, they were there, but also digitalization of management flow. So all the COVID systems were digitalized. From testing, contact tracing, vaccination, everything was digitalized. And that's also what we want for other diseases, as it is a plan also for the government in next coming period. Going very quickly, this was the structure that was put in place to cope with COVID. As you can see, I only highlighted on digital because that is the topic is all about. I just want to let you know that within that structure, they did not forget the digital, and that's where we have data science and IT solution, a team that's had the IT programmers and statistician and analyst. We found this option was very efficient to combine data scientists with the IT programmer because most likely one team will be producing the tool that generates data, and another team will be using those information. So it's always important that those who are producing tool, they get an idea from those who are using that tool in order to know which tool they have to produce. Otherwise, there is always a mismatch in terms of the tools that we have in place and the tool that we are going, and the information that we need to process and the way it has to process it. So during the COVID, we had to handle that issue by putting that team in one place so that the tool that I produced, people are very sure that the information that they're going to get, they know how to use them, and they know how it is going to respond on the real time. So that was a smart way of managing these things, and it worked. Apart this one, on laboratory, what we had to do, the first things, this is the structure that we had before. This was one of the toughest decisions that our leaders had to take, because there is a routine that laboratory knows how they do things, and there is also the new norm that we need to put in place in order to manage the pandemic. So previously, there were like almost 9 steps in order to get results from laboratory. The step 1, they will pick sample, they will collect sample from anywhere. It can be at health facility, it can be at the center, or anywhere. But that sample has to go with a form. So that was a best practice in laboratory. They were saying that there is no way a sample can go without a paper form. The second, that form and the sample were transferred to the National Reference Laboratory. A National Reference Laboratory, they had a team on desk which has to process those paper-based information shared with the sample and then send it to the processing center, which has to link a paper and a sample, and let alone send those information in testing machine and also in data entry team. After all, then the information, the results from the testing will be sent to the data entry system to link the result with identifier of individual and then print the results to the patient. But also you can imagine during COVID, how people would access the information, how people would access their results. If you have to be tested, do you need to go to the hospital to get the results? That one was also a problem because we were in the lockdown, people they are not allowed to move. Second, we didn't want people to be on crowd because of transmission. So you can imagine all that burden that was there in terms of just issuing the results of someone who tested COVID. And remember that Rwanda decided to go for the systematic testing for COVID. That's what we did from the beginning. So everyone had to be tested as long as you were a suspect. So we were expecting millions and millions of tests that has to be there, and then imagine how to give them results. So that was really a big challenge at the time. Then the team, the scientists decided to restructure the way laboratory flow works. And that's how it comes. They shortened it to make it on 3 stages only. 1, there's no more paper-based information. We only need to register digitally all the information and only keep sample with a barcode on it, and that's it. And that one was even very simple because by the time people is registered in the system, information are already synchronized at national level. So the people from laboratory, they can see people who are already registered in the system. They don't need, they're just waiting a sample to be there so that they can link and test. So that was short and simple. And then once the sample reached to the laboratory, it was just to verify and send it immediately to the testing room. And testing room, we had also a system, and then the result will get immediately to a patient. And this one seems to be simple, but if you look how effective it was and the contribution that's brought out in terms of managing the pandemic, it is enormous. Next. Then there was also a way of managing. As you know, in Rwanda, we had to use, at the beginning of pandemic, all COVID cases and suspect were managed either in the treatment center or in an isolation center. We did not have home-based care at the beginning. So everyone who is a suspect, they will take him to isolation center. If you test positive, they will take you to the treatment center. And then there is also the structure, the decision makers and the public health experts who are there, who want to use those information to take a decision in terms of preventing the disease, in terms of coming up with a new strategy, and in terms of knowing where there's a problem. So, and this one required a lot of information, which are real-time data. And then we came up with a decision of digitalizing also the entire system so that we can have a central server where all the information related to COVID can be accessed and then sent to the people who are taking decisions. We had several dashboards and monitors, depending on what you're doing, to give you information that can help you to take a decision. So, some of our adaptive strategies that we had were empowered with digital tools, digital solutions. Let's start with the systematic testing that Rwanda adopted at the beginning. The second was systematic contact tracing, epidemiological surveillance, and the community engagement and awareness. And then lastly, I will talk about the home-based care, which was last, but I'll be focusing on the technology used during those strategies. Next, please. Well, remember that at the beginning, there was no rapid test. All tests had to be done using PCR, and they believe PCR is costly. If you look at the time, it was between 30 to 100 USD cost per one test. So Rwanda decided to go for the systematic testing, everyone. So we're expecting millions of tests that we had to conduct. And unfortunately, the tests were also not available as expected. And then the team of scientists here in Rwanda, they decided maybe let's try to find another approach that we can use to optimize the testing, but also minimize the cost. And that's how the team came up with a poured testing approach later on, which was basing on mathematical approach, mathematical models, which helps us to determine the effective sample size that can be poured for one test. Simply, it's like one test that could be conducted for one individual. We had to pour one sample between 20 or 50 individuals, and they use the same kit. So the approach is that if that's poured sample tests negative, the entire pool, it means those people, they are negative. But if that pool one tests positive, then you had to repeat again, you do one by one. So that one was a little bit smarter because we could minimize the number of tests that people have to use. So, and later on, this was also published into Nature, and you can see many people referred it and many people used it. So it was really a good approach in terms of following a decision that the government took in terms of reducing the transmission by testing everyone who is a suspect or everyone who have been in contact. So we managed to achieve that one, but using an innovative way. And then the second problem was, how are we going to test people? How people are going to get results? The solution was quite also simpler. We had to think in portal of results, the system that we have to put in place, where people can serve himself. You just have to put your identifier and you get your results and so on. And I believe this system is still working. All of you have been using it, and you can see how many times you tested, if you have tested positive, negative, you can see in longitudinal approach. And those are amount of data that are here, because You can see some people that have tested more than 100 times and so on. But if you merge all those information, maybe, why not? It can come up with a longitudinal data that can maybe help on discovering something else. So this is something that we have, and you can distinguish the PCR and the rapid tests. So those are things that people, they need to put in place at the beginning in order to solve that problem of results, how people are getting results. Next. We talked about contact tracing. When we talk contact tracing, it was really contact tracing, a systematic contact tracing. If you test positive, the team will come to you. They will ask you questions, the people you have been with, and they will classify all the information that you provide into 3 categories. We used to call it red ring, yellow ring, and green ring. So the colors are depending on vulnerability. The red one is those are people who are like your direct contact, and those are people who need to be tested immediately, the people that you need to look for them, because the probability of being infected might be high for them. And then the yellow one was like, okay, the people you have met, but the risk is not very high. And then green, the people like you meet, but there's no much risk, so we don't have to have worry. This one was just to prioritize who we have to focus in on the right time. So, and then we could do the same to each level. But remember that when you are doing contact tracing, you need much of information, and sometimes those information are not there, because if I went to the bar, like what happened in some of our experiences, someone was in bar sitting with people, but he doesn't know the people who was around that person. And those people are also at risk because they are going to transmit. And then we had to come up with some mathematical algorithm models that will help us to identify the nearest people who are in the same environment with that person, but also that's in collaboration with the other institutions, the government institutions, providing different information, like can use the network that you are using in that area, the antenna that you are using, the telephone, and so on. So all those information helped us to identify the people at risk. Then what was next? If someone found in that list, they were calling him and asking him to go and test. So we had to come with that. But also, there were some strategies in order to reduce the spread. Some people needed to have like a bracelet so that they cannot spread in the community and so on. Next, please. And this one also was published. We made a scientific paper, which is a secondary transmission partner COVID based on contact tracing in Rwanda. So it was published in a scientific journal and talking about all the information. Then another point was this epidemiological surveillance. We had to identify the areas that are known as high risk. And this one we couldn't do it manually. We had to use the geolocation systems software, the GIS softwares. So we had to know where there is a high risk, the bars, the outlets that are open during the lockdown and so on. And this one, we had to take a regular surveying, testing people from that area so that we can see the transmission rates in that particular area. Next. The same, we used to do some random sampling in the street to see the positivity rate and so on. So those are the system already here. But each of the intervention that we are doing, as I said, it's collecting data, and those data has to have a tool that will help us to have those information, and those are amount of information that we have. So that's why I'm saying there's more information, but also we need to work on more how to use those information and tool that's enabling us using them. The similar approach in terms of surveillance, at the beginning we used to have our men in uniform escorting the truck drivers from other countries so that they cannot stop anywhere to avoid any contact with local people to avoid the transmission and so on. But this one was also we found that maybe we can do it better in terms of using technology, and that's how we came up with the GIS approach, where we can monitor trackers. Then our men in uniform no longer going behind the trackers, but we can see if someone stops, we can ask, why are you stopping, and other things, so on, using the technology. And those are also amount of information stored and used during COVID in order to help prevention. Similar, we use a drone in terms of mass communication in different neighborhoods. I'm sure you might have seen it in your community and so on. But also, we involved the community health workers through the ASCOV system, where now the community health workers can also test for COVID using the tool that we have developed. That's also a digital solution in place, and we could accumulate those information to be used for the decision makers. And then another big decision was to shift from treatment center to home-based care approach. Something that was done very quickly, as you can see around November 20, when we started doing that. But also immediately we were linking with the treatment, because we had some way of symptomatic treatment, favipiravir and other treatment that we're using. And those people can take it from home, and our people can just use a new system. Next, please. Can use a system, next, called WellTel, the one Professor Rich presented, to follow up those patients. And this is a real-time interactive tool where you follow your patient from home, and you can know what is going on. You hear from them if they have a problem, and so on. And this one helped a lot, because without having this, it would be even difficult to start home-based care, because there was no linkage between the patient at home and health provider. So we needed something to intermediate between the health provider and the patient at home. So next, finally, this is how, at the end, we ended up with a system for COVID, digital COVID system, which has 3 parts. The main was the public one. People could do some self-selection, like if you feel like you have some symptom, you go just to 114, and they will ask you symptom, and if the system tells you that you might be positive, then they will advise you to go for testing. We had also the WhatsApp tool doing the same, but also for those who came abroad, you saw something, passenger locator form, that's information that you are using. That was also there. But all those things were linked to the testing, and the specimen can be taken, and the results. And if you find yourself you are positive, you have 2 things. You can either go for the home-based care or the treatment, depending on your situation. And when you are going for if you are positive, you are going for the treatment at home-based care, immediately you go for the WellTel and so on. So that is how summary of whatever I said looks like in terms of digital system that we use it. But what I can assure you that all the COVID interventions that we used here were basing on evidence, were basing on digital solutions, and that's how we come up with the good looking. So thank you very much for your kind attention.
That is top-notch science, right? That's really, really amazing. And no wonder our country has actually been at the helm of controlling this pandemic. You know, at every stage of the pandemic, we've had something to do. And I think this shows the great minds that were behind that. Thank you so much, everyone who has contributed. Without digital solutions, we could be really, really behind. But what are the lessons learned throughout this process? What are the lessons learned by using a digital health systems? So we're going to listen to our next speaker is the Senior Program Manager for Infectious Disease at CHAI, and She is someone experienced, 10 years of experience in the field. She comes from a background in international public health, and she has been working in this field for so long, and she has a lot to share with us about what are the lessons that actually we have learned throughout supporting digital solutions implementation. Let's welcome Alida Ngwije with a big hand of applause.
Good morning, good afternoon, good morning, still morning. Good to be here, and I'd like to start by thanking the organizers of this symposium for giving us the opportunity to share lessons learned from implementing digital solutions. And it's good that I'm following Mohammed, because he spoke about what the country did in COVID, and I'm going to share more applications in other disease areas, because COVID has really taught us to start leveraging some of the lessons learned in other program areas. So my presentation will be focusing on hepatitis program, because as we know, the country has launched the plan to eliminate hepatitis C in 5 years. And CHAI has been a close partner to the government in this area. And I'd like to share how we have been using digital solutions to actually accelerate the elimination of hepatitis C in Rwanda. Next, please. So the presentation will be subdivided in three main areas. So I will speak about the overview, how CHAI is working with the government of Rwanda to advance the digitalization of the health sector, and zoom into hepatitis C elimination and share, of course, lessons learned throughout this journey. Next, please. Yes. So being a partner of the government, it's not like working on one program. So CHAI has been working with RBC on implementing the digital solution that Mohammed just spoke about. And apart from hepatitis, we're working on a cancer program to eliminate cervical cancer in the country. And we're using digital solutions as well in that regard to make sure that we don't lose women that are screened for cervical cancer. And we also are working with the division in charge in RBC to continue strengthening the COVID systems that are in place. As Mohammed mentioned, there are some, there's a lot of data that is accumulated in the system. So we are currently working on how do we make sure that this data can be analyzed easily. And we are working on creating an analytical system that is separate from the COVID system to be able to simplify and make easy or make smooth the process of data analysis. So I won't go in details about cervical cancer and COVID, because Mohammed already covered the big part of COVID. I will use just hepatitis as an exemplar of how digital solutions can be applied in other disease areas. Next, please. So in summary, I won't take you through the whole story of the hepatitis program in the country. I'll start with right after when the country launched the elimination of hepatitis C. And at that time, Rwanda was managed to achieve price records of hepatitis treatment. And currently we are providing the hepatitis treatment to Rwandans at only $60 US. I mean, the treatment is free, but the country buys it at $60 US. And this has allowed the country to actually intensify the case finding. And in 2019, just before COVID, we had around 1.5 million people screened and over 2,000 people treated. And these numbers, in papers, you would find this data in registers across facilities. And at that time, we introduced as well the rapid testing of hepatitis. And this also simplified the method. So in the community, anywhere in the country, you could get screened and just be initiated on treatment right after. So this 2019 was really a year that increased a lot the numbers of people screened for hepatitis. Then in 2020, the movement continued. Actually, I think hepatitis was included in Imihigo for district hospitals to screen a certain number of people per year. So this also revolutionized the case finding strategies that were in place. So at that time, we did not have a strong M&E system. So we're talking about millions of people, but you could not, at the central level, you could not have access to these numbers. You will just hear facilities reporting, but you could not sit and analyze what you have as a central team. They could not have access to this information. And of course, the quality was also not good because the central level was not involved in verifying the amount of data, but also the quality of data that is being collected in facilities. So in 2022, today, of course, COVID happened and a lot of momentum was, slowed down. But where we are today, we are aiming to achieve the target that we fixed ourselves when we launched the elimination. So this target was to screen 7 million Rwandans and treat at least 80% of those who will be positive. So this is the national target, and that's where we are aiming. And to make this happen, next slide, please. To make this happen, we knew that, yes, we are screening people, yes, we are treating them, but we realized that we are losing patients as well throughout the journey, because some people could be screened, they don't come back for viral, they could be receiving viral, they don't come back for treatment, or they get treatment, but they don't come back for the last exam of SVR12. And if we're talking about elimination, all these gaps have to be closed. So we designed, together with the hepatitis program in RBC, we designed an approach or a strategy we named Closing the Loop that helped us actually to assess the entire cascade of care and really identify where we are likely to lose people and close those loops. So what is there on the screen, it's not what was happening, it's what we expected to happen, like if we don't do anything. So these are issues we thought could happen at each stage. But the ones in yellow are the ones we identify that if we don't close these ones, then we may not reach elimination. So if I continue saying closing the loop, this was the exercise we did, and the interventions were created to actually close the loop in this cascade of care. Next, please. So I'll speak about 2 digital solutions we came up with, because we realized that there was no way we could respond to that without a digital intervention. So we designed 2 main digital interventions. One was to have a patient-level system that will allow us to follow up on everyone who's initiated in the cascade. And having them initiated in the cascade and recorded in the system was not sufficient. We had to make sure that we keep reminding them to come back when they need to come for the next appointment, because this was actually the cause of people being lost. They will go home, wait for the facility to call them for picking up their results, and the facility may not call, or the patient will come and find that the results are not available, they get tired. And again, we are talking about hepatitis, a disease that is very silent, so you don't feel sick for you to continue seeking care. So we had to really make sure that patients have a certain communication with the facility. So the 2 main interventions are the one we put in place. And next, please, next slide. Before we start implementing the 2 systems, this is how the data M&E was by then. So in 2015, 2017, before the launch, every data that the country was using was captured in registers. So you can imagine all the district hospitals having their own registers, and someone sitting at RBC looking, for those data, how they would struggle. And then we evaluated a bit. We went to an Excel-based database, but this also came with its own challenges. You have duplication, you have data loss, because they will have to send those Excel sheets to the central level. Some emails don't reach, or they reach, you lose them. So it has another story of, it was a small improvement, but really did not solve the problem. And then we moved to DHIS2, but as an aggregated system. So this was HMIS actually, which is aggregated. It will tell you how many people are screened, but they won't tell you who finally ended up being initiated on treatment. Next, please. So when we designed the digital solutions, it was actually to respond to the problems that happened in those previous years. And that's where we designed a patient-level system that is now allowing healthcare workers to enter data in real time, and that data is sent to the central level on the same day. So if someone is sitting at RBC and they want to know what's happening in all the facilities, they can just have access to that. So the system was designed in working with the program, really going in all the indicators and making sure that we capture everything the program needs, and the system was put in place. Next, please. So this is currently how we're collecting data using the DHIS2 systems. I will maybe explain a bit about the difference. There's DHIS2 aggregated and the DHIS2 patient level that is similar to what we use in COVID. So the one I'm talking about here is the patient levels. We call it DHIS2 hepatitis tracker that we are using to monitor every step of the cascade of care. So, and again, in terms of decentralization, currently hepatitis services are available at every health center in the country. Every facility plus all the health centers. So we're talking about like 560 or plus facilities that are using the system. So you can imagine if everyone can connect at the same time and enter data at the same time, but also the central level having access to that data at the same time. So please, can you go back a little bit? So this is the trajectory that a patient has to go through. And we're making sure that at every step, being it at the health center or the hub for viral loads, or again, the health center for treatment, and the hub again for SVR12. So SVR12 is the a viral load exam we do to confirm that a patient who was initiated on care has been cured. So we have our system designed around those steps. Next, please. So to just give you an idea of what we've managed to achieve is today, from any facility in the country, if you want to know how that facility is doing, you just go in the system and run this order, like command, and the dashboard will produce this. So this is an example from a health center in Rusumo. And I don't know if you can see, so the green is the number of people screened positive. And the blue is the number of people, the number of people tested for H. So the cascade of care is a patient is screened. If you're positive, you tested for viral. If the viral is positive, you put on treatment, and you continue the treatment, and then you come back for the last viral load. So the colors here are for those steps. And this is in the system at one health center. So you can have it again at the district hospital level, at the referral hospital, and even more important, at RBC and MOH level. So this is what we are using. And for a country that is in the elimination journey, this is something we need. Because based on what WHO is requiring to achieve elimination, a country needs to screen 80% of the eligible population and treat at least 80% of the ones that are positive. So how will you tell if you've screened 90%, or how will you tell if the ones positive have been treated? So you need to have a story for each patient for you to be able to evaluate. So for the country to actually be ready to evaluate hepatitis C elimination, they needed a system like this that can tell them the progress, but also when it comes to evaluate, then they will use the system. So next, please. So that was an example of how these solutions that we put in place are helping the program to actually accelerate elimination. And again, the system is equipped with an SMS. It's exactly like COVID. It's equipped with an SMS that is sent to a patient once their viral load is positive, to call them, remind them that you need to come and collect your results, or you need to come and pick your treatment, like an SMS that accompanies the patient throughout the cascade of care. And that has helped to minimize the loss to follow-up, but also to reduce the turnaround time. Because patients would go home and wait for 2 months. When they come back, it's not late, but they should have come early to be initiated on treatment. I'll go back to that a little bit. So here I want to put some light on other initiatives we took after creating the DHIS2 system for hepatitis. We realized that there are other systems in place. There's a system used, it's called VLSM, that is used to send the viral results to facilities. So what we did was, once we had the system in place, it could not operate by itself. So we have now integrated the VLSM and the DHIS2, and this is helping the program to avoid actually copying results. Because for DHIS2 to send out an SMS to a patient, viral results have to be in the DHIS2 system. Yet we had viral results only in VLSM. So the nurse will have to take the result and copy them in DHIS2 to generate the SMS, which could bring errors, and nurses sometimes don't have time. So we linked the two systems to just make it automatic. And today we can see the fruit because results go faster, their quality is better, but also users are more comfortable. They don't have to spend time typing them. So integration of existing system has been a very, very driver to achieve what we are achieving today. Next, please. So this is a summary of a recent survey we have conducted. I have not put all the questions we asked to the users, but this is a summary of what the users have told us after they have started using this system. So it's good to keep checking on, the users, how comfortable they are, because sometimes you can put a system in place and no one is comfortable using it. So we have this system to continue informing us, are we doing well? Do we need to improve anything? They also responded about the training methodologies they would like. I did not share this here because it was like a lot of details. But we asked the question about training because during COVID, we trained them virtually, we trained them with videos, we trained them with, we mixed training methodologies and they wanted to know which they prefer. So they ended up telling us that the face-to-face works better, but at least we got information on what worked and what did not. So this survey showed us that actually users are, very happy with the system, though it has been there only for like a year and a half, but the response is already encouraging, and we feel like if they can use it for hepatitis, it can easily be replicated for other disease programs. Next, please. So some of the lessons learned, next. Some of the lessons learned throughout this process, I'm trying to summarize, but happy to develop during lunch or after the symposium. But just zooming into lessons learned, we learned that at the planning stage, you need sufficient time to actually understand what you need to put in place. Because users, if you keep updating the system, they will get tired. So they want a package that is well elaborated, that will work, and they get familiar with it. And here we're talking about nurses at the health center who are not very conversant with IT infrastructure. So you need to really give them something that is easy to use, but also to make sure that it's the last version in the ways possible. Because we've seen that when you start changing things, then they get confused and they may even reject the system. And then it's critical to involve all relevant stakeholders in the implementation. For example, when we started training, we trained, of course, the nurses, but with time we realized that we need titulaire de santé on board, because at the end, a nurse can be on night shift, tomorrow there's a new one, but when you have like a titulaire involved in this and understanding, the adoption is easier. And then in case it's an ongoing program, it's always good to see or to prepare how you're going to absorb the existing data, especially if it was in paper. So with the hepatitis program, we're very struggling to have all the data that was accumulated from 2015 into DHIS2 because the way it was collected was not consistent. And we're trying to match it with something that's almost perfect. So the match is not working, but at the end, we know that as a country, we need that data all together. So it's always good to prepare on how do I absorb the data that has been accumulated before. And then when you reach the system development phase, it's good to have a comprehensive but concise indicators list. That's what I was saying, that you have to make sure that you minimize changes and updates, especially considering the users who are not very, they have limited literacy in IT systems. And then systems that involve patient notifications seem to work better. I think COVID has showed us that really, without those SMSs, I don't know how we will do, but hepatitis is using the same to really bring back the patient and make sure that they're engaged and we minimize loss to follow up. And again, we need to map out potential interoperability opportunities. As I mentioned, VLSMS was one of them. But again, I think in COVID, we're also trying to maximize, like, what do we have in the community, what do we have at the district levels, so that we really have systems that talk to each other and minimize standalone systems. Last one, I think. Next, please. When it comes to system uptake, it's good to demonstrate to the users the importance of the system. Because sometimes they feel like this is an RBC system that they just send to us, but when they start generating like results from the dashboard, like what I just showed, it's actually encouraging them to feel like this thing is easing my work. So that ownership will come only if they understand that this is for me, not for RBC or for the DG of hospital. And again, stakeholders' involvement in regular data quality. So as the system develops, it cannot look beautiful. Like, I think that's a beautiful situation I showed, but in reality, you have some discrepancies. So you have to continue accompanying them really to understand their data and make efforts to improve it. So we have to have a team of people that is following up on that until the users are comfortable. And then in terms of sustainability, so because as a partner, we all know that the funds sometimes are not there to stay. So you have to make sure that there's a sustainability way. So initial steps of implementation, these are the ones we're talking about, can be very easy to implement. But when it comes to adoption and familiarity and institutionalization of the system, then we need more stakeholders, but also we need to make sure that what we've embedded in the users can stay. So the section after implementation is actually the one that needs to be more strengthened. And then integration with different electronic systems that is in place is crucial, as I kept repeating. But maybe to summarize for hepatitis is that without this system, it was going to be very hard for the country to actually measure or monitor the progress towards elimination. But I think this is just an example of what digital solutions can do to improve not only patient outcome, but also achieve big agenda like elimination. But I think it should not be something that is disease-specific. It should be replicated easily with diseases that have similar pathway, but also can be customized for diseases that have specific unique pathways. Yeah, I think that's it. I think this is the last slide. We hope that we can eliminate hepatitis C using digital solutions. Thank you.
Indeed, we need to get rid of those old books, old books. My professor is here, and there's one condition that we've been following up. And we had this small old book with the patient comes in, like, get the book, and try to find what was the HSID last time. But now we are also going digital, and thank you so much, Prof, for the help. So, a lot of information, right? So much information from morning session. I'd like to welcome everyone to stand up and stretch. By stretching, we're going digital by stretching. So we're going to write the word digital using our body. So we start with a D. Let's go. Then there's an I, right? Then put a dot. Then there's a J. An I again, another dot there, then a T, an A, then L. Please, thank you. You may be seated. So we're going for a conversation, and the audience, looking at you, you want to also intervene. So we'd like to go for a panel discussion where we're going to discuss about strategies to increase the use of digital solutions to improve health. And our moderator is Dr. Brenda Asimwe-Kater, who is a public health physician and epidemiologist with over 18 years of experience, leading and providing strategy direction to public health programs. She is currently the country director for
Thank you so much, Dr. Magnifique, for that introduction. And good afternoon, everyone. It's a pleasure to host this panel discussion and to see the room full. That shows the interest in the digital health technologies and solutions for innovative healthcare delivery in Rwanda. So you've eaten a lot this morning, so now it's time to chew a little bit and digest and regurgitate some of your information back in questions. And we have an exciting panel discussion that is coming up. We have an expert team of panelists that cut across policy implementers, academicians, researchers, and practitioners, program implementers. So prepare your questions. I know that we are running a little bit of time, so we'll try and finish before 1, but we'll ensure that it's engaging and very interactive. First on the panel discussion is someone who needs no introduction. We've already heard from him, the Permanent Secretary of the Ministry of Health, Mr. Zakeya Kereme, and he has been the PS at the Ministry of Health since July 2020, and he inspires to see public finance management in the health sector improving, contributing to better health service delivery. And we just heard from him this morning that he's also very passionate about digital health transformation in Rwanda. So please join me to welcome PS. You're welcome. Please come and take your seat. Next on the panel discussion, on the panel is our keynote speaker, Professor Richard Lester. He also needs no introduction. I think we've heard from him about the wonderful technologies that he's been able to implement not only in Rwanda but in several countries across Africa. Welcome, Prof. Lester. We have an expert from the Ministry of ICT, Mr. Antoine Severa. He currently works as a Government Chief Innovation Officer at Rwanda Information Society Authority, RISA. I think we all know RISA, which is a government authority affiliated to the Ministry of ICT and Innovation that is mandated to coordinate the implementation of the national ICT agenda towards becoming a knowledge-based society. Mr. Antoine holds a Master's of Science in Software Engineering and has been working in the IT industry for close to 2 decades. And his current work involves driving digital transformation initiatives across different government sectors, including Ministry of Health as well, and also playing a catalyzing role in ensuring that innovative technologies are not just developed, but effectively used, and securing the strong participation of private sector, which we know plays a very important role. So, Mr. Antoine, you're welcome. Lastly, but not least, we have Prof. Stefan Jansen, who is an associate professor in neuroscience and has worked at the University of Rwanda since 2011, and he's currently the Director of Research and Innovation and working to make the college a leading health research institution in the region and beyond. He's also the founder and the current head of a mental health and behavior research group and leads on a number of internationally funded research projects that cut across mental health, gender-based violence, psychosocial well-being, and different methodological approaches. He is also the co-chair of the Health Research and Policy Symposium that is currently happening. So please welcome Prof. Stefan with us. So we'll have a couple of questions, and then we'll open up the floor to the audience in the room. And we know that we've had a lot of information this morning about how digital health interventions are really supporting patients, they're supporting healthcare workers, health systems, and really generally improving data systems, all with the end goal of improving patient access and care. And for the patients, we've seen examples of how the digital health interventions have assisted in client communication. We heard from you, Richard, about the patient voices, and it was interesting to hear how we can interact with patients beyond just the health facility in the room setting, but using that information from them online to actually inform the practices and evidence. We've also seen examples from Rwanda on the COVID vaccine certificates, SMSs, patient scheduling interventions. And for the health workers, we have electronic health records that are also, interventions are also supporting clinical decision support, telemedicine, referral coordination, and so on. For the managers in the room, I'm sure you're using information systems for logistic management, also disease surveillance systems. We've seen that, health financing, facility management. It's a broad range of benefits and interventions that can really support the various stakeholders in improving effective healthcare delivery and innovations as well. So I'll start with UPS. We have had several successes from Rwanda, but what is really behind some of these successes, and what can other countries learn from what is happening in Rwanda to implement some of these digital health interventions and really having that drive for digital transformation in the countries?
Thank you very much, moderator. We have so many factors that are leading to the success that we are seeing in Rwanda, especially into the health sector. If I can begin from what I can consider being success factor number one is the leadership. The leadership which has a clear vision of where we want to take Rwanda and the health sector in particular. So the choice we have made in terms of our policies and strategies with clear targets and indicators, I think this is a key success factor. So the other one is like the infrastructure, especially when we are talking of success into digitizing health sector. I've seen all what has been done in a very short time during the COVID pandemic, and this couldn't have been possible if we were starting from scratch. So we are starting from somewhere. We are starting from a country where most of the infrastructure need has been planned and catered for. If you look at the current digital coverage of the country, looking at the access to internet, access to mobile phones, if we did not have them enough, I think the success stories that we are discussing here couldn't have been able to be achieved in a very short time like we did in COVID. So other things is coordination among stakeholders and working hand in hand, information sharing, but we have also seen a very high level of compliance to the people of Rwanda, especially during the pandemic period where everyone was new to COVID, but the people showed high level of compliance and trust to the country systems, where based on information that was shared, they could accept to stay at home for some time to avoid the spread of the pandemic. We have also seen the people are willing to embrace change and they are ready to use technology. So those are the key success factors that I can look at. But of course, we have a very good foundation where we are starting, and the collaboration among key stakeholders is also very critical. Thank you.
Yeah, thank you so much. I think you've highlighted leadership, coordination, but also the users, the compliance, and the easy adoption of some of these new technologies. Magnifique had started off saying that he was afraid of using telephones for even medical consultation, but now that is clear. It's really adopted across all the different facilities that we are interfacing with as patients. Richard, from your experience in other countries and your current experience in Rwanda, learning from the past going forward, what are some of the strategies that we'll need to put into place to quickly scale up, to quickly increase the adoption of digital health technologies among the patients, among the healthcare workers, the managers, really to achieve that equity for all that you talked about? Yeah.
Yeah, thank you for that. And I think one of the points mentioned earlier was having a clear health goal for the agenda, for what is the problem that's trying to be addressed, and then adopting around that. And as the Honorable Permanent Secretary mentioned, also being flexible. COVID, I think, changed, so we had a lot of ideas pre-COVID, but we've really had a chance to test and renew a lot of those ideas in an urgent, pressing manner during COVID. The speed with which we were able to work with Rwanda to launch a program way surpassed my home country in Canada, many other locations, and I'll even say, actually, I was at one of our neighboring countries in Rwanda, a larger one. I mentioned because we were working on some programs there, what we were doing in Rwanda, and this head of the hospital just said, oh, if they're doing it in Rwanda, it must be good. So the reputation is proceeding from the leadership, I think, point of view. And I think one of the things I've seen is the government leadership as well. Like many places, as I was mentioning earlier, have either a very strong private sector, but they might have a disjointed government sector, or the academic. And the Rwanda Biomedical Center being integrated academia and evidence-based leading within the program. In fact, the private sector, we're trying to set up our regional headquarters now in Rwanda because we feel it's so favorable of a place to work with a good reputation. But a lot of that is also the leadership of the government here. Things tend to move forward with a clear vision. So I think it's that integration that really I've seen that is really remarkable.
Stefan, did you want to add something?
Yes, I can on the same question. Yes, maybe I'll tell a bit on the experience that we had in this and the development at the University of Rwanda. Also starting, and I think it's an important point that we hear time and time again, you start from the problem, you don't start from the solution. And going from a problem and then moving forward and not having your technical solution first, but using the technical solution to really solve the problem. Now, so in the experience that we had, I think when you look at these presentations, one after the other, it looks very impressive. And it looks like, oh, they just did 1, 2, 3, and then everything was done. But I think if you really work in digitalization, you come to learn, and we all have our different backgrounds, right? Many of us have a health background, and so you have to learn about what digitalization really is. And one of the initiatives that we created at the University of Rwanda, specifically for the College of Medicine and Health Sciences, is the United for Health initiative, which is a platform that has a physical component, but also a digital component, which really aims to be a portal that facilitates a whole range of functionality in creating successful partnerships. And so it was started with a very simple observation with colleagues at the university and colleagues at the college of problems that we were all aware about. And it started at a time, Brenda, when you were still counted among our colleagues at the university. We started those discussions together. and with many of the colleagues. And so we had some concerns, like what can we do to improve the quality of the research thesis of our students? Sometimes they just do a thesis because they have to do a thesis. And then at the same time, we hear from the hospitals and the health NGOs and private sector partners. They come to us with observations and they say, this is an issue that we see. And we couldn't really link them together. Another issue is also the quality of our internships, which is a same issue. So from the university, we want to improve the quality of our internships. And a really important element, and I think a very prominent element, is how there is many opportunities available for our students and for our staff and for our partners. And we didn't manage to make use of them. And I'll just give an example that's really telling of something, because nobody is solving the problem. 2 years ago, I was talking with the head of the European Union, and he was talking about the Erasmus Plus program. He said more or less there is 100 scholarships available for Rwandans. And last year you took up 7. And he said, so please move forward. So it took years and years. It's not a simple issue to collect those kind of problems and analyze the problem and understand them. So that took us years. And then you say, okay, I understand the problem. Now it's going to be easy to formulate a solution. So that also wasn't easy. But one thing we did is we started thinking about it as a project. We attracted some external funding, and that facilitated the project. We now had some human resource to get a solution. And the solution is to create a United for Health platform. And then we said, okay, now we are done. The work is over. We've understood the problem. We analyzed the problem. We talked with our partners. They agreed this is the problem. Then we found a solution. We talked with our partners who are supposed to be using the problem. They said, this is the solution. It's over. So we created a website, and then no users, because the website was not sufficiently friendly. And so I think that's the reality. And then you iterate again, and you involve again many people. So this whole process is surprisingly, and then you learn that web development is not the same like web programming. And then just, if you allow me, I know I'm taking a bit of time, and then there is still one more component of complexity. And also in some of the presentations it came about, it's for the users. It's sometimes you need some mindset change. So one of the things that we do, this platform can only be successful if all of the partners contribute. For example, knowing about scholarship opportunities or research grant opportunities. We all have a bit of information. And the tendency at the moment is kind of, let me keep it in my drawer. You never know when it will be useful for me. While we know that we become more successful if all of us share that information, and then all of us can benefit more. So there's this mindset component, and you need to talk with partners and engage partners. So my message really is that the complexity of digitalization is very high, and it is not programming alone. It has many, many components.
Yeah. Thanks for highlighting some of the challenges along the pathway, right from conceptualizing to design to implementation, and then uptake and adoption, and eventually sustainability of a digital pathways. Tony, I know that your ministry is at the helm of the digital transformation in Rwanda for the entire government, including the health sector. And I know that you mentioned there were initiatives and several strategies that you're putting into place to create this enabling environment for transformation. Could you highlight some of them and maybe some of the challenges that you anticipate as we are achieving this ambitious transformation project?
Thank you very much. Yeah, it's great to be here, first of all, with so many tech enthusiasts here in the room. So we've been having plans for now close to 2 decades. And the objective is really how we become a digital nation. we've had the Smart Rwanda Master Plan and different others that preceded the plan. So putting things into context today is to say, what have we learned from the COVID-19 pandemics? And where we are going is to look at digital to be the default way, not the optional way in how we approach our different programs, be it in the economic development, social development, but also on the sectorial strategies. So globally, at the country level, we're working towards improving on connectivity. I think PS alluded a little bit on the investment we made in infrastructure. No one knew that COVID will come, but thanks to the investment we made maybe 10 years or 11 years before the pandemic, we're able not only to address the pandemic, but also ensuring that the economy will continue to function, whether in lockdown or in some other ways of restriction. So we want to expand it further in terms of more affordability, accessibility. The previous speakers discussed about the role of mobile telephony. We've been relying a lot on USSD and SMS, and we're talking about smartphone penetration about reaching about 18%, and we want to grow it further and to see how we could get more elaborated use cases using smartphones for the health workers, but for the population in general. So working on a scheme that aims to put a smartphone at least in every household, and that can be multi-purpose. You can use it for health purpose, you can use it for education as well. We also be making more investment on large data infrastructure. We've seen cases here on how they leveraged on big data and analytics. We have a lot of data sets across different sectors, across different systems that we built over the years, and we're putting platforms to integrate them, specifically in the health sector with the Health Information Exchange, continue the digitalization of all the medical records at all levels, speeding up adoption, both in terms of device, but equally important on digital literacy. Want to be a digital nation, and this is being constituted by the digital people. So very ambitious plans for digital literacy at all levels, general population, but also creating a pool of experts. It's great we've seen example in data sciences, in analytics, in different systems were put in place. We want to increase the critical mass of our engineers, software developers, AI experts, so we can see more elaborated use case and platform. Last but not least, the role of the private sector. We're building an innovation ecosystem. We've seen great ideas. We'll not mention many of them here, but the private sector has been instrumental, and the startups to find solutions. We've seen the drones, we've seen a couple of solutions that were made thanks to the partnership that we have with them, to continue that further and have any innovator across the country, whether it's in the capital city or in any of the provinces, the districts, whenever they have a good idea, how do we bring it to the market, and how does it help to solve the challenges in the particular context here related to the health of and well-being of our population.
Thank you so much. I think that really sets the foundation that we need to build upon for the digital transformation in the health sector. And it's important that you highlighted the role of the private sector. I think we need to, as the health sector, have that cross-learning from public-private, but also with academia and research. So we need to have that triad, all speaking to one another and learning each other's languages. So thanks so much. We'll open it up now for discussion. So if you have any questions, comments to the panelists, please raise your hand, and a team with the microphones will come right to you. Please state your name and your institution, and then you can have your question. We ask that you make them very concise and to the point. Yes.
afternoon. Can you hear me?
If you could stand up so that we can see you, please.
Good afternoon. Thank you for the really interesting discussion. I had a question on the point. My name is Paula. I work with FIND, and I had the point about private sector innovation, because one of the challenges that I think was alluded to earlier and comes up in many settings is the need to integrate digital innovations, data systems, particularly for health, so you have one system as opposed to many fragmented ones. And then when you look at innovation, markets, of course, often thrive on multiplicity, having many options. That's the genesis of competition and innovation. Seems like there's a friction, and it's something that comes up in FIND's work as well, between having many digital companies and innovations, but at the same time to have one system that can be managed and rated by the Ministry of Health. So I was curious to know, especially I think from MOH and TT, what the strategy is for balancing that tension.
Thank you, Paula. We'll take 3 more questions, and then we can address them at once.
Thank you so much. My name is Augustin Manrachiza, a final-year pharmacy student from Rwanda. I want to address to the PS from Ministry of Health. I really appreciate the integrated digital program. I have seen that Rwanda is developing, which is one system and one record, so where all health workers, health centers, district hospital, referral, and at national level data will be connected. And I want to ask that I have not seen where the community pharmacists are connected, since when the patient or the clients, they don't get medicines from all those service centers, they come to the community pharmacist, and yet the community pharmacist, they don't have access to the patient record or patient history, and the successful of the program need a pharmaceutical care or patient education, which is based on the history of the patient. It prevents the interaction and ensure the best outcomes of the patient. So I want to ask how they are expecting to integrate the community pharmacists to ensure the success of the program. Thanks.
Thank you, Augustine. Yes, please.
Thank you very much, and I'm Yasenta Mushumiza. I work for CHAI. I have a question especially to the PS and only in terms of health financing. These technologies, they are costly, but we're expecting to be effective in saving more life. But do we see any cost saving, at least to allocate the saved amount to fund more health intervention that we might still have in the country? Thank you.
Right, if there's no one last question.
Hi, good afternoon. My name is with CDC Rwanda. My question goes to Richard. It's really good to reconnect with you after about 10 years when you first did the world level study in Kenya. My question is around just appropriateness of tools. You talked a lot about the NLP, Natural Language Processing tools, and then sometimes the appropriateness of the application in a setting like in Rwanda, where you said most of the interviews were conducted or interactions were conducted in Kinyarwanda, but we know that some of the NLP tools are not built for other languages than English and some common languages, the global languages. So I'm thinking about the loss in translation and just how well those tools fit in an environment like Rwanda. So how do we make sure that, like in the early stages of development, that they are tested and appropriate for this environment, so that whatever interpretations come out of them are truly meaningful within this context? Thank you.
Thank you so much. I think let's have those questions, and then we might have another quick round thereafter. Paula asked about the role of a private sector and trying to promote innovation in the platforms that are being used versus having a harmonized platform, especially for the health sector. And I think, Antoine, you can take that.
Thanks. This is an interesting question. I think, as discussed before, the role of the private sector is instrumental, and especially the startups that are bringing new technologies and innovation. In the sector, definitely, we're not going to have, when we talk about consolidation, is not to be saying that we have one system for everything. We're actually promoting interoperability. Interoperability is actually the way any system fits in the existing ecosystem. And even when we talk about single patient record, this has to be understood in terms of federating different data under a common set of information that will be related to a given patient. So our efforts has been one to have clarity on the priorities of the sector. I think Baptiste discussed with you about the blueprint which shows in the next 5 years, where is the health sector going to put effort? What key systems will be in place? And what are going to be the timelines with that? So this blueprint shows really where we are heading, and gives also an opportunity for people who are in the research, the academia, the private sector, to look at where we have the gaps and then where they can fit in. So that will be the first phase in terms of maybe giving her more comfort that we are not going to have a single systems, but a set of systems that will be talking to each other. With a caveat that will avoid repeating, reinventing the wheel whenever we have already a system. It's better to build on top of what we have, and bringing up solutions that are creating really values, not to come and say, please replace this with mine, which I think is a better solution. Could be better, sometimes could not be better. So beside that, as the Ministry of ICT and Innovation, we're also working to streamline our regulations to become more agile. The way we've been procuring is more traditional in many spaces, in the government and also in some other partners and stakeholders. No one could have assumed COVID will come, guessed that it will come, and then no one had time to sit down and really work on the terms of reference. So we're looking at the way we become more agile, having our data sets open to the public so they can come up, we experiment things in the sandbox, and relaxing our procurement regulations so that we can open up for innovation. So this, we think, is definitely going to help grow even further the role of the private sector by giving them more opportunity to solve real challenges on top of what we already have. Thank you.
Thank you so much. I think the next questions were addressed to PS. There were two questions about where do community pharmacists fall within the HIE, and the other question was about the health financing mechanisms for the digital transformation.
Thank you very much. I think Baptiste, the Chief Digital Officer of the Ministry of Health, presented the 6 registers for the Health Information Exchange. And the first register was National Product Catalog, where all the health commodities shall be registered. So in our plan, the plan is to include the whole process from the patient registration to including consultation up to the discharge. And the community pharmacist shall also be integrated and have a link to see medical prescriptions by doctors so that they can get them and be able to dispense medicines to the patient. So in our plan, the community pharmacist is also planned for, and should be catered for. So the other one from Yacent was about however much the investment in IT solution is very much expensive. And he was wondering if we see any level of savings when we compare to the status quo. And to me, I would say we have more than financial savings. We also have financial savings, yes, but we are saving more lives when we become digital. So the only savings should not be estimated in terms of cash, but we are also making cash savings, and we can elaborate. But the more critical saving that we are making by shortening the process is we are saving more lives and trying to be more responsive to the disease. I think Dr. Pacific was trying to imagine if he is in his consultation room and being able to get all medical records from historical medical records from all the clinics where a patient has visited. You would imagine the level of precision this would bring to the doctor and the likelihood for a better health outcome to the patient. That's a big saving than not having the information in present. So it is worth investing, and it saves more money than we can imagine. But we are also saving a lot of money. You can imagine, for example, if everyone had to come and get a test result at the laboratory, all those travel costs, time spent to go to the lab, the queues, spending, even increasing the likelihood of contamination. So those are big savings that we are making. And of course, also paperwork that we normally do. If you look at the spaces where current hospitals are archiving patient files, those are big spaces. And we have so many staff working in this kind of work, which is actually, if it becomes digital, everything, the space is going to be used for consultation and patient rooms. So I think we are making a lot of saving in investing into the digital, the digitalization of our health sector. So it is worth investing. Thank you.
Thank you, and this is a great opportunity for the researchers and academicians to do cost-effectiveness studies and learnings that, that can be obtained along the digitalization journey in Rwanda. Yeah. Richard, you had a question about the language appropriateness of some of the tools.
Yeah, thank you. That's such an important question. I want to make one quick follow-up point too to the gaps when we evaluate. The last decade or two has really been involved about establishing the infrastructure of informatics, health records, data collection, the DHIS, do all that important work in the health system. But where COVID really changed in our opportunity, and it's going to lead into my language question, is now about actual patient care. It's about actually follow-up. The biggest gap in our health systems and where we were brought in is, and as Mohammed Samakula mentioned, there were no tools to actually follow patients up. It's one thing to have a test, it's another thing to make sure they receive it. And following on that follow-up, that is going to be what really changes the health system going forward. And I think, and the other point about COVID is the population is more ready now than we could have ever imagined. Even in, I remember our CEO of our hospital in Vancouver before the pandemic was saying we wanted 50% of visits to be virtual by 2030. Because of COVID, it was about 90% within a few months. So the population's already ready, the practitioners are used to it. Now we need to really have this unique opportunity to deploy. To the language question, which I think is a very important one, we're still at that cusp between what I'll call RI and AI, real intelligence and artificial intelligence. And And we're going to get there. And as we develop and train the tools, you're right. When we looked at the translation from Rwanda, and there's tools like Google Translate and others, we found out quickly they weren't quite sufficient to capture the true essence. So part of our work and working with RBC and then in our ongoing work with the Center for Excellence in Data Science at the African Center for Excellence here is going to be, we deployed translators to make sure that the translations between these communications in Kinyarwanda and or other languages were accurate. And there was over 300,000, I think, conversations to analyze, so that's just building. But not only are we just going back and translating, we're trying to build into the systems a learning system, learning evaluation system, so as the systems get deployed, they continue to get better and better at understanding the languages, for example, that are being used. So the NLP has machine learning, which is very good at discovery, but it still at this stage requires a lot of personal or supervised learning by experts, and I think that's where we are at this stage to ensure that we're getting good data. Thank you.
Thank you. Thank you so much. We have time for maybe two to three more questions. So please don't go back home with burning questions. And we also have some gender balance. There are only late gentlemen that have put up their hands. Okay.
Thank you. Thank you. The great panel that presented this morning. Thank you, the panel that is sharing now. I have a few observations. My name is Edith Munyana. I'm now working with IntraHealth USAID Ngobji activity. I've been working with the Ministry of Health for the last 17 years. IntraHealth, just 2 weeks. I just have two observations. Digital health or any digital solution is a journey that needs everyone to participate, not only the engineers, not only the doctors, but even the audience. It's a mindset change. You can have all the smart solutions you can get, and people will stick to using their papers. So culture mindset change is a journey that we all need to participate in. And it's an investment worth investing in because the benefits go to us if we save a life. If I give you an example of an activity that Ngobji is working on now through e-learning of community health workers, when we deployed 100 smartphones to community health workers, the community health workers that have been leaving their homes, their everyday activities to go get trained at health centers, at hospitals, now get trained at their homes with their mobile health phones, that is mobile health, and they're able to do the right treatment while they're staying at home, not leaving their day-to-day activities. The other example is an app that is also Ngobji implementing that is called Ya Health, Youth Adolescent Health. Is one app that is being used to sensitize the population, the youth, the young adults, on the information about their sexual reproductive health. Where do I find this information? How do I use a protector? Where do I find an after 24-hour pill? All those examples are there for the youth using mobile health, and it's saving the young girls on getting unwanted pregnancies and all that. So technologies, digital health, I find it taking 3 processes. The technology part that requires the infrastructure. That means I must stop. The infrastructure solution, then the process, who implements. If you have the great solutions, but let's say healthcare providers or hospital leaders, health center leaders are not implementing that, it will not succeed. So our role as the entire nation, as all citizens, is required to make digital health successful. Thank you very much.
Thank you.
Thank you. My name is Dr. Jenuta. I'm a senior lecturer and research coordinator from Mount Kenya University, Public Health Department. I have a question. Sir Richard, I've seen something in terms of medication adherence to HIV positive patients by using the digital solution, sending the message so that they comply with the medicine. So, and this can be scaled up with the other services like improving antenatal care services, especially for us in Rwanda where we still have a lower prevalence or uptake of the first antenatal care, which is leading to the not completing the recommended antenatal care services. It's a good approach by using the digital solutions to improve the other health indicators. So my question is, now for those projects, they have been funded. So how can we ensure after the project ends, the sustainability of those good health, digital health solutions? Thank you very much.
Thank you. We'll take one more question.
Thank you. My name is Elizabeth Uwanyirigira. I'm a medical doctor. I work with USAID Rwanda as the health system strengthening advisor for USAID Rwanda. And actually, I will not go into details on how USAID supports the system, supported the digital for the health sector. Of course, thank you, Edith, for mentioning that USAID, Ingobi, and some other activities are supporting the digital piece in the health sector, because we've been supporting the different systems, the ERMI for supply chain, for data collection from facilities, electronic medical record, Rwanda Healthcare Analytics Platform. But I have two observations or questions that I want to ask the panelists. The first one, actually, I want to hear more about at least two top challenges that you are facing in terms of digitalizing the health sector. I understand there are some challenges that I've been in the sector for over 15 years, and I have some of the challenges that I've seen. For example, some system requires annual license fee. How is it, how the government is planning, for example, to have that in their plans? That's one of the examples that we've been seeing, or how does the government is planning to, for example, have experts in maintenance, for example, because we used to see some systems are not functional for some times. Then we ask ourselves, do we still have to wait? I'm giving an example. An Indian company to come and just do maintenance. The flight to pay, the consultant, those things, I understand. I want to really to understand more. Those are the key challenges, actually, I wanted to highlight. We've been facing, and of course, the connectivity, how is the government, trying to put efforts in terms of to make sure that the connectivity is good to accommodate our digital plans. Another question, sorry, Brenda, sorry, another question. Do you have an idea on how much the government allocates to the efforts for the sector? Maybe our colleague from Lisa will tell us, do you have an idea? Of course, the allocation is being done or read by the Minecofin. Maybe they are not here, but how do you have like a plan or a guidance or saying that X amount will be allocated to digital? That's something that I really want to hear from you if you have an answer. I understand you may not have an answer, but we really want to hear. And what are the efforts to mobilize resources to support this? Maybe let me say this example to digitalize the health sector. What are the efforts in terms of mobilizing the resources?
Thank you so much.
Thank you.
Yeah. We'll take a question from the online audience. One of them asks, one strategy for increasing the use of digital technologies to enhance health is to reduce paperwork. According to the World Bank 2020, internet penetration in Rwanda was less than 30% of the total population. I think that figure has gone much higher now, but Tony could update us. And the question is, that indicates that digitalizing health is not well known among the rural residents. Is there any bilateral agreement between the ministry and telecoms or ISPs to maximize internet or phone users? I think the other question was more of a comment about a client who had to attend rehabilitation services during COVID, and if there was a plan for digitalization in the rehabilitation services, but I think that's a solution that we probably need to develop. So thank you so much. I think we'll stop there in the questions and go straight to the responses in the next few minutes. The first comment from Edith was more about the mindset and culture change that is needed, and the e-learning interventions that are happening also right to the community level. So it's not just at the health facility level, but right at the community level. And Richard, you had a question from Dr. Eugene about the mHealth technologies among the people living with HIV, I think, as an example. So could you go ahead and answer that?
Okay. Yeah, I'll comment first, but I think the related question in that was sustainability beyond projects. The applicability can be proven in HIV, can be proven in COVID, but they're often through grants. So I think my esteemed leadership colleagues here can better address that. But from our perspective, again, one of the most cost-effective things you can do is the better use of resources you already have, and that means adherence and follow-up. Improving that is very cost-effective, and we've shown that, others have shown that. So from a sustainability point of view, improving adherence and follow-up is probably near the top. In terms of projects getting funding beyond in the transition from research funded to donor program funded or backed even through the ministry. Rwanda is again one of the places why I think we're so excited to be working in this environment versus somewhere I've been where those projects really do sometimes die after the funding period, the 5-year cycle or whatever it is. But here we have such an integrated, what I've felt, and we've actually managed, we actually got some external funding from Grand Challenges Canada and CIHR to launch the COVID WellTel program in COVID for home-based care in Rwanda. But it was only for a year or two. But actually, even when that funding ran out, we were all working behind the scenes, and we kept it going because we said, this is a pandemic. The pandemic wasn't over in 1 year. And we had to, sometimes you're forced to find ways to sustain it. And now what's happening because of that success and coming back onto building on things that already work, because it worked well for COVID at scale in a national program, we're starting to look at, can we just build off that for the TB program, for the non-communicable diseases program, et cetera. And by using a platform that's agnostic to the condition, you can really have, be pregnant and HIV and diabetes all at the same time and be followed up in a platform, which really makes it, the scalability much easier. So I don't have the magic. I think most countries, in fact, are still looking for the magic answer about how to sustainably finance digital health services. But I think we have one of the best opportunities here, maybe in the world. So I'm going to leave it to the colleagues to discuss. Thanks.
Yeah, and maybe this would be a good point, first starting with you, Tony, to talk about the sustainability elements, really from a broad multi-sectoral approach. But also talk about some of the challenges that were raised by Elizabeth in terms of the maintenance and the really the costs associated with that. And if you could also touch about strategies to increase internet penetration in the country.
Thank you very much. Those were great questions, and I think they're quite aligned with the top two challenges that Elizabeth alluded to, and also Edith, the culture and mindset change, and how we create more, tech-savvy citizens, and even thinking of training doctors and health professionals straight from school on the different applications when they reach the market. They're already conversant with some of them. Sustainability is a key issue, and I think one of the ways, and it's also part of the challenge, is to see how we work towards a common goal, aligning all our projects towards the ecosystem, not trying to build an ecosystem. This means aligning our efforts toward the blueprint. We have a sector that has identified the goals. When we bring a solution, we avoid reinventing the wheel and reuse what is already there. Another issue in terms of sustainability is we're focusing more on technology. There's virtually a technology for almost any challenge that we have here. And the pace at which technology moves is going to solve even more and more problems. So we need to address the human side, which is the most important in my opinion. Are we having the right team in place? Have we trained people ahead of starting this project, not starting to train them after you've deployed the solution? And then when we are acquiring different solutions, are we buying them separately just because we have funding from whatever sources and seeing how we procure using our own channels? Maybe it's a time to rethink and say, how do we bring synergies with existing projects there? And having, like, we've seen this in a way we acquire license at a national level. We do some bulk purchase and we are able to buy computers, we're able to buy the licenses at a much cheaper price. But if you're doing it at a smaller scale on a project, you might not be able to achieve economies of scale. There was a question about also the local industry. Yes, you mentioned about we relying more on external providers. It will still be a mix of the two, but again, it's a mindset change where we have to also jump that gap and start to believe more in locally made products, which are also equally good. We're starting to see emerging big players who are also partnering with smaller ones to bring more solutions on the market. That's also another way of bringing in more sustainability, not only in terms of cost, but also in quality of service. We've seen institutions that will suffer because they don't have the required support on time. You need maybe to, ship someone to take a plane and come, and sometime in the COVID, that was even impossible to have them come to intervene locally. So the question also was on sustainability on the funding. Yes, we've put in place mechanism to work together with the Ministry of Finance. We are an integral part in the discussion in the budget planning and the processes. Before moving to getting government funding, there's extensive discussions that are made between the institution together with the Ministry of ICT to see the priorities and align them towards, to see the project and align them towards the priorities within the sector. And we encourage this practice to even go further. We do it for the national budget, but it would be good also to see this is done also by different sources of funding, development partners, grants that we receive, to see if they are clearly aligned with the priority of the sector. Do we have a way to reduce the risk of not being able to sustain them after the funding is over? The last question was on connectivity. I think we're putting more efforts, as discussed, to bring more last connectivity. Government made significant investment into fiber deployment across the country. We've connected a lot of health facilities. Those who were not on the fiber, we brought them with wireless, with 4G LTE, and we're expanding it more for more institutions to go on the fiber for more resiliency of the connectivity, and going all the ways to have all the health posts, seeing how we can have all the community health workers also equipped with smartphone. And there are schemes we are preparing for smartphone acquisition. In the past, even currently, when you go to buy a smartphone here, you pay upfront the full cost. We're looking at models on how we can stimulate the acquisition of smart devices with putting in place means to pay them in installments. And there are already activities which are earmarked, and funding is already secured for the next 5 years to beef up on the last mile connectivity, having more health facilities connected, health professionals equipped with skills, and also engineers growing their number to be able to support us in the different activities for more sustainability of our investments. Thank you.
Thank you so much. PS, in the last question, I think there was the question about budgetary allocation, and also really your remarks about the sustainability component, and your parting shots as well. We are out of time, so we will have to close the panel discussion. Yeah.
Thank you very much. I can a little bit speak about some of the sustainability challenges. I think we have not mentioned that in our plan to digitalize the health sector, we are using a local team now, which addresses most of the challenges related to software development and licensing fee that was being paid annually. And now that we are using local team to develop the software, I think we are going more sustainable in terms of avoiding the licensing fee. But of course, like Tony mentioned, we also need to consider that outsourcing is not always a bad option. Sometimes it is also a better option that we have to go. But if you go for it, how do we make sure we streamline it properly to ensure it is not going to create sustainability challenges? So that's what we always work hand in hand with the RISA to ensure we are aligned. So for the government budget allocation to digitalization, as well as the resource mobilization efforts, I think for the health sector, at least since the very first time when we established a health sector digitalization plan, we have seen good collaboration from both the Ministry of Finance and the Ministry of ICT in terms of advocacy for resource allocation, government budget allocation, but we have also seen good collaboration from our stakeholders, development partners, and all active in the health sector to contribute toward the whole sector digitalization plan. So we have different forums that brings us together to discuss the priorities of at every stage. And of course, we also discuss budgetary allocation and see how we can be able to finance any gap. So I wouldn't say that we are having finance constraints, and as Tony said, a big part of the plan is covered. In the morning, PS Mini ICT mentioned about the financing that government of Rwanda has secured through the World Bank for digitalizing the public sector in Rwanda, and the health sector is among the priority sectors to be financed by the funds. So we are very much optimistic that resource constraint is not going to prevent us from achieving our digitalization targets. Thank you.
Thank you so much. Stefan, parting shots, and then we can quickly move up.
Yeah, okay. Yeah, I wanted to respond also quickly to Edith's question about this mindset change. As we think about digitalization, and the enormous complexity about it, like Tony was saying, you want to involve the private sector, you have many different players, then you have to integrate everything together. So there is, I think, from technical people, the complexity is so enormous that you just let me figure it out and let me put this technicity together. But as Edis was saying, in the end, we need to make sure that those technical and digital innovations are ultimately leading to better care. So there is one component is that the technology is informing us for public health reasons, and therefore it's really important to capture the data. There is a small example maybe that I can give from a story I read in Switzerland when they were digitalizing their healthcare system in Switzerland. There was an enormous resistance from the healthcare personnel in the hospitals who refused. They said, no, the paper form is better. We don't want to go into this digital. Part of it was actually people are very intimidated by that. And one reaction can be that you say, well, they just have to be quiet, learn about it, improve, and then the problem is solved. But I think the more interesting way to look at it is, as digitalization experts, we need to help them because they are providing care. And it's not necessarily the nurse. The best nurse is not necessarily the nurse that does the best digitalization or the best information, reporting. Maybe the best nurse is the one that has a lot of empathy and really care for the patient. And so, yeah, so there is a certain tension. So it's an additional layer within the complexity of what we are trying to achieve, and we shouldn't overlook.
Thanks. Tony, 2 seconds, parting remarks.
2 seconds, I'll say, let's not wait for the next pandemic. Let's start now to continue to make investment, change our mindset, and don't overplan. Be agile, start something, and then revolve on it, fine-tune it as you move forward.
Thanks.
And I'll use the opportunity to actually thank the people who brought me here and allowed me to be part. So the Rwanda Ministry of Health, the Rwanda Biomedical Center, and the university partners that we're working with, and the people of Rwanda, because I think one of the things I've heard about Rwanda the most is people are its greatest asset, and I think we've got a slate here. So the reason I'm here and Flu made this trip today is because I actually believe Rwanda has one of the best chances to make this digital journey work for people. I just hope we can contribute to be part of that. Thank you.
Thanks. And finally, PS.
Thank you very much. Mine will be basing on the challenges that has been mentioned about the mindset change. So I would say, let's not fear change. Let's embrace them instead, and then take over the new innovations to improve our service delivery for better. Thank you.
Great, awesome. So we will really, I think the panel has demonstrated some of the key guiding principles in digital health technologies. They have to be user-centered, user-friendly, but also with sustainability and scalability in plan right from the beginning, and having the patient at the center, or in whichever scenario, the beneficiary at the center. And Tony also highlighted the importance of reusing and improving over new systems where applicable, and using open standards. So thank you so much. It's been an exciting panel discussion. We are out of time. I know we could have gone on and on. Please give the panelists a round of applause. Thank you so much. I'll hand over back to the MC, Dr. Magnifique.
Thank you so much. It was great. And thank you so much, the audience, for the inputs and discussions. I think that was something to note. And we actually have more to come in the afternoon and even tomorrow. Would like to say that we've had a great morning sessions, and we've come to an end of the morning part. We need to re-energize again, so it's time for lunch. Lunch is served at the restaurant at the hotel. So this is KCC, this is the center the conference center. But they also have Radisson Blue, the hotel, which is just like by the corridor. If you walk to my far right, there are people that are ready to give us directions, and I've been informed that each one of us will be given a token to present to lunch, just to make sure some hotel order to make sure that is done. So please make sure you find our people who are going to show us. They are in blue t-shirts. They are going to help us with that. Second to that, we have the afternoon session that is going to be a breakout session. Some people are going to come in this room. Others are going to the mezzanine, which is upstairs. And again, there will be people to direct us. I'd like to remind you to go through the agenda. It is there are different researches that are going to be presented. So please go through the agenda and decide where you're going to be. And both of them are going to be great sessions. Yes, I think they are putting us the agenda. More so, we have the abstract book that was sent to our emails. Please refer to your email. And if you did not get it, please make it to my far left up there, to the tech people. You'll find someone who's going to help you to get the abstract book. So I know you're like, please stop, we need lunch. So have a nice lunch. We have a group photo. I'm going to ask those people to stay behind. The chair and the committee, the conference committee, yes, the conference, they're going to stay behind. And the presenters for the morning sessions, please stay behind. That includes the people that were here for the panel. Other people, you can take selfies as you're going out. And we are here. We're going to be exact here at, can we make it 40 minutes? It kind of digital, right? You can be a little bit digital as you're eating. And by 40 minutes, we're here at 2 to start the next session. Thank you so much. Oh, in the group photo, we would like to welcome the ambassadors that are here with us to please, and other partners, to please come for a group picture.
I am online. Can you see my video? That's fine. I'm not that interesting anyway. Excellent. Great. Thank you, Dr. Chewbacca, and nice to be here with you virtually. The intention had been there to be there with you in person, but unfortunately, COVID got the best of our household last week. So I'm really grateful to the organizers that I still can participate. I always say during the pandemic, the online technologies have allowed us to still be able to do the work. It's just not nearly as joyful. And I do really wish that I was able to enjoy this event with all of you there. But I picture a room full of friends and collaborators. So thank you again for the opportunity. Next slide, please. I just want to briefly start by introducing our study team. This isn't everyone who's touched the project. I'm sure there are other colleagues in the room who've been part of the work. Sadaskar Hakizimana, Felix Ayanzoga, Eric Gaju, Jean Dudu Gatete, many people who've been advising us as we've gone through this work. But I did want to take a minute to introduce you to our current study team. This idea that it takes many people with many different types of expertise to pull this work together. So Dr. Chewbacca, who just introduced me, is currently a co-PI on some of our qualitative work and some of the work developing post-discharge instructions. Fred Katera, who I'm sure many of you know, has been supporting some of the surgical site infection work. Other folks I want to point you to, I'm not sure if they're in the room right now, but Laban Bikaramana and Andy Ngina, who've been really implementing and advising the study from nearly the beginning for the last 5 years. Both Laban and Anne will be presenting in the next room over some of our work, so I encourage you, if you have time, to learn more about that from them. And then two other people I just want to point out. This bottom group on the right are different students that I work with and fellows that I work with on this project. And two of those are also at the conference today. So Monique Abimbaye, who is a PhD student with the Africa Center of Excellence in Data Science at the University of Rwanda, is working closely with Siona Prasad, who is on the bottom row. Siona is a Harvard College student, and they are working together this next month at the Center of Excellence in Data Science, doing some data science training, and they're presenting some of our work today. So I encourage you to reach out to them if you see them and learn more about the work that we're doing. Next slide, please. It's oftentimes easiest for me to start at the end in terms of what we're working towards. And so our goal is to develop strategies to support home-based care for women after cesarean delivery in rural Rwanda, and to really engage this cadre of community health workers that the Ministry of Health has pulled together to support this home-based care. Next slide. Just a bit of background that I'm sure is familiar with many of you in the room. There's increasing C-section rates, which has been linked to lower maternal morbidity and mortality. However, just the fact that we're having more cesarean deliveries means we're also seeing more C-section related complications. And the most common of those are surgical site infections. And around between 8 to 48% of women who deliver via C-section in sub-Saharan Africa go on to develop surgical site infections at their wound site. For a Rwanda-specific context, approximately 15% of women are delivering via C-section. And then, as again, I'm sure everyone in the room knows, community health workers are supporting women during the postpartum period, but the C-section specific follow-up for these women requires that they travel back to the health center for follow-up care. Next slide, please. So why home-based follow-up? So I'm just citing a few results from various studies, and you can look up these papers if you want more information, or email me if you'd like me to send you the papers directly. So some of our earlier work estimated that 11% of women in our studies go on to develop surgical site infections. We actually see a lower rate in our more recent studies, approximately 6%, and that work should be out soon. We found over various studies that long distances are linked to poor maternal and neonatal outcomes. Women have reported in qualitative work that C-section follow-up is physically and financially burdensome. And then more recent work, we estimate that the C-section cost itself up to the time of hospital discharge is financially catastrophic for 23% of women, but that this increases to 77% when we're accounting for follow-up, the follow-up after discharge, where the woman has to go back to the health center for C-section specific care. Next slide, please. And there's many exciting developments in Rwanda that allow us to pursue this work uniquely in Rwanda, but I think really sets the precedence for what could be happening in this area in the region. So one, again, I'm speaking to an audience that knows this already, but the Mara phones really creates a technology platform that we could leverage for this. The work that I'll be presenting all runs on Android smartphones. We're specifically designing it to be compatible with Mara phones. So that's an exciting development. And then the Ministry of Health goals to empower community health workers with smartphones also makes this a more viable intervention, given that they have the tools, and it's about developing additional resources in implementing those tools. Next slide, please. So over a series of studies, we have demonstrated that community health worker-led home-based follow-up was feasible and acceptable. And so we really do believe that home-based support of these women is possible. However, one of the challenges that we faced across our work is that our approaches to surgical site infection diagnostics were failing. And I've cited some papers here, and I'm not going to go into all the details, but effectively, we have things that look promising in certain settings, but as soon as we try to do this in home-based settings, the accuracy, the ability to accurately diagnose surgical site infections decreases. And so one of the things I want to focus on in my next few minutes is just our strategies to try and improve the quality of surgical site infection diagnosis. Next slide, please. So I want to give you two examples, and again, I'm happy to provide you more information because I'll have to go through these relatively briefly. The first example was what we're calling a more traditional telemedicine approach, where the community health worker traveled to the woman's home and captured an image of the wound. She texted that image to a general practitioner, and then the general practitioner reviewed the image and gave a diagnosis of surgical site infection or no surgical site infection based on the review of the wound image. Again, we found that this was feasible. About 79% of women who received a diagnosis within 1 hour, and I think it was around 92% received a diagnosis overall. So it was possible to implement this type of intervention. However, we found that it had, compared to a physical exam that was conducted the next day, relatively low sensitivity, much lower sensitivity than we would feel comfortable with deploying this in practice. And I just want to point out that Ann Nyingina has a poster on this particular study with all of the details, and so I encourage you to track down Ann in that poster if you want to learn more information. Next slide, please. The second example I want to provide you is using image-based diagnostic algorithms. So over a course of studies that we've been implementing prospectively in Karehe in Rwanda, we've been collecting images of the wound and then also corresponding GP-led surgical site infection diagnoses. And so we're using this batch of images and diagnoses to train algorithms with the goal of, in the future, we could use these algorithms to take an image of the woman's wound and be able to diagnose the surgical site infection just based on the image in the algorithm. Next slide, please. And we have two recent papers out with this work. So the first is just taking a wound image from the phone. So it's literally, we talked about the Mara phones, there's cameras built into the phones, taking a photo of the wound, and then we're developing software so that this can be processed processed in real time on the phone. And what we found is we were able to develop an algorithm that had about 80% sensitivity and 65% specificity. If you can just advance to show the next paper, please. The second paper we just had out is a really exciting development where instead of taking a photograph of the wound, we're actually taking a heat profile of the wound. And so here you can see my colleague, Laban Bikaramana, taking what looks like a thermal picture. And we're using those to train the algorithms. And you can see with these thermal images, these heat profiles, we're able to get about the same sensitivity, slightly higher, but much greater specificity. So in addition to improved diagnostic accuracy, the other thing really exciting about this type of algorithm is our algorithms are specifically developed for women in Rwanda, and we think will perform well in Rwanda. But the question is, what happens if we want to take what we've learned in Rwanda and apply it in Uganda or in Ghana or in Mexico? And we believe these thermal heat profiles will be more transferable to other populations because they'll be less sensitive to the skin tone of the women who the images were captured on. Next slide, please. So just in summary, we believe that home-based follow-up after C-section provides an opportunity for more affordable and less financially burdensome post-operative care. We've demonstrated feasibility and acceptability. However, we must be able to accurately diagnose surgical site infections before deploying such an intervention. Our machine learning models are currently the most promising option for this, and we're continuing to explore this work. Next slide, please. Next slide, please. As for next steps, we just received some new NIH funding where we are looking at trying to get this onto an app and to implement it prospectively to evaluate its properties. We're working with a company. No problem. Okay, thank you. Sorry. Vincent, I'm back. Let me know when you want me to begin. Thanks, Vincent. Thanks, Vincent, and I'll be very brief. So I just wanted to note that we have an exciting new opportunity that we're starting, which is taking this machine learning algorithm and putting it onto a phone so that it's standalone and it won't require internet connection to actually process the image and to provide a diagnosis. And this will actually be complemented with some other functionality, for example, assessing for danger signs after C-sections or giving general counseling about the physical activity or mental health supports that women can access after C-section. And that app work is being developed by the Rwanda-based startup Inside of AI. So we're grateful to work with them. And then I also just want to point out some of the excellent image graphic work that Bertrand Mugabe from Partners in Health Rwanda has been developing for us to complement these counseling tools. So look forward to that work, and we can talk more about that if there's interest. So last slide, please. Just want to say thank you to everyone who's involved in this work. Again, there's so many people, it's impossible to name them all. But we're certainly happy to hear your questions, and I can point you to the right people to answer them if I'm not the right one. Thank you. Thanks, Mohammed. And it makes me so happy to see your face and hear the question from you. So that's really great questions. So in the next round of research that we have available, there's going to be 2 validation studies. So I would personally argue that it needs a little bit more validation before we want to adopt this nationally. But in that validation study, one is just assuring that the tool that Inside of is developing truly is usable. So they're doing a lot of user interface in the design phase. So we're working with community health workers, with clinicians to make sure the tool is usable. So we would want to make sure that's the case before we deploy this on phones. But the other part is just making sure that, in addition to the surgical site infection diagnosis, which also needs some more validation, that if they're assessing for things like deep vein thrombosis or, other danger signs, that they're accurately capturing that So the next part of the study would have that validation, and then our intention is to work with the ministry to show the full set of results and say, you know, this is what we have, and we'd be interested to support scale up. Certainly, the system is ready for scale up, right? In terms of community health workers having the phones, and I think there's most of the evidence is there. So I'm optimistic that soon we could go to full expansion if there's interest on the side of the ministry. So that's a great question, and that is not one that I have good answers to. So, you know, definitely, if you have some thoughts, would love to hear them. You know, it has the benefit of being electronic, right? So it could trigger into systems that you would want it to trigger into in terms of, you know, if there's a fee for the service, which oftentimes my understanding is community health worker visits don't oftentimes have a fee, but if there is a fee, what is that fee? If there's pay for performance, you know, it could trigger into those systems. But what those exactly are, that is not so clear to me. So I think your question is a great one. The systems are there that it could feed into those, but what it's feeding into, what it's triggering, I would love you to advise me on that point, or others at the ministry to have insights on that. I could hear the first part, but not the latter part. It's a great question. And a complicated answer. So, you know, one of the things that we tried that I pointed out was just taking a photo of the wound and sending it to a GP for diagnosis. And we got great specificity with that. Decent sensitivity, not excellent sensitivity. One of the challenges we had with that was when multiple people looked at the image, different people would give different diagnoses. And so you might say infected, your colleague might say infected, and I might say uninfected. And, you know, how do you deal with that? So, you know, we've not totally given up on the idea that telemedicine, that more traditional form of I text an image to a doctor might work, but it didn't work in our first study of it. The machine learning algorithm on the images, the gold standard for that, what we're training those images against is a physical exam by a general practitioner. And the reason that's our gold standard is because that's what a woman would get if she went back to the hospital for post C-section follow-up, right? So if she went back to Currahee District Hospital and wanted her wound assessed, a GP would look at it and say it's infected or it's not infected. So we have that batch of images is what we're training it against, and are getting decent accuracy. So, you know, you and I could go back and forth and say, well, it's not perfect accuracy, but it's pretty good. And then we would have to discuss like what is good enough. But to your point, you know, we are using images, but we're using images to try and recreate the gold standard of a physical exam. So grateful. Take care, everyone.
Okay, thank you very much. Do you hear me? Okay, my name is Dr. George. Calling from Imperial College, London. I just have like a couple of questions. So the first one was in the cohort you mentioned in, I didn't hear Rwanda. Rwanda is not part of this first cohort? That was my first question. And the second question, is this program focused only on the medical student background, or someone else should just part of the program? If I can just make a quick follow-up. So is there any criteria for someone to be named as digital leader, health leader? Yes, yeah, but like if this program tend to be like international, I guess. So how does I think it would be better if the criteria should be common for everywhere. Cool. Thank you.
from RBC can also share the experience and compare from what Paola has been presenting here.
Thank you for your good presentation. Actually, based on your presentation, I come to notice that what brings about non-compliance from coming to test for COVID-19, based on your digital ICT solution, you have changed it from 45 minutes to 20 minutes. Can you tell us what is the impact does that reduction of time have created? One. My second question, please, is that how do you tackle non-compliance? Because South Africa, they are kind of having some similar scenarios with Nigeria, because people do fear that if they test you COVID-19 positive, then the whole community will start saying something. I'm a victim of scenario. My colleague is here. When I come back to Rwanda, when I travel to see my family, I just arrived to the airport, Kigali International Airport. They're just telling me, you stop there. You are COVID-19 positive. It was very terrible for me that day. I was staying at Ruburizi University. It's a University of Rwanda government quarters. Most people here, they know it. All my neighbors, they don't follow through my house. The road leading to my house and the quarters, nobody is following. These are my colleagues. I refuse to go to the faculty, so it's the same. I just want to ask, what are the solutions, or what are the things that you did to avoid all for those people? Because even me, had it been, I know there is a way I can skip from the airport not to be tested, I will do that. But Rwanda is a serious country, you cannot.
Yeah, thank you for sharing your experience, your personal experience of being tested COVID positive. And actually, one of the questions about how you've been dealing with potential stigma, compliance as well. Yeah, those are issues you want you actually to speak about.
Okay. Thank you. Okay, I'll start with the first question, which is the easier one. The second one is quite thorny. In terms of the reduction in time, I wish I had the numbers at my fingertips, and I can share those with you afterwards. But effectively, what we're able to see is that by reducing the time, the drop-off between people who had completed the symptom screening and got tested reduced afterwards. That was something that we're monitoring on the back end. So the 1 in 5 is the overall throughout the lifetime of the study, but in the earlier weeks of the study, that had been higher. And so the effect of the reduction was to show that now, okay, people are actually able to stay through and complete the continuum. And like I said, I will get those figures, specific figures, and share those with you. I don't want to say something incorrect. But it really helped us then in some sites where you see that despite reducing the time, you're still seeing a high level of drop-off, then that can also make you think, is there something else happening? Is there, and it's not just about technical training, maybe the way that you're speaking to the patient doesn't encourage them, maybe the other factors, whether there were so many other things that could affect. Also, as vaccinations started rolling out, there were more people dropping off because they said, oh, I got vaccinated, I don't need to get tested for COVID. So there were many things that came up as a result of that observation that we saw through this platform. And yeah, we can connect afterwards for more details. The question of compliance is a challenging one. I'm going to choose my words very carefully. I think, and the reason I'm saying that is because I'm not a policymaker, and I think that's ultimately something that needs to be addressed by policymakers. But it's a question that comes up often, and especially when you're doing community-based testing. They say, for example, if you're testing somebody at a bus stop, they test positive when they get on the bus. Now, all the people on the bus, how do you stop them from actually taking their transport home? And the honest truth is you can't. Unless you have individual ambulances to take everybody that tests positive back to their place of residence. I think we have really, in the early days of the pandemic, when there were just a handful of people and there was that, You remember that song that was going around, do you know somebody who knows somebody? And there was just, one people in a few hundred that we knew that had COVID. And now it's, especially during the peak of, of these waves, it's community transmission is at an all-time high. And I don't think that any testing approach will ever be able to plug those gaps completely. It also becomes a question of human rights. To what extent can you limit someone's ability to move? But what we do hope and believe is that by empowering people with the knowledge, they can at least be able to make those decisions for themselves. And we've done similar community-based testing work in a number of other countries. And one of the key messages that we always try to encourage is that understand that you having a test result is also just a matter of personal responsibility. So if you have a family at home, understand what that means and give the patient that responsibility to take their health, take their life into their hands. I think we've seen in many places, including South Africa, where I worked for many years, especially in TB, and there were very heavy compliance measures put around drug-resistant TB. People were getting locked up in facilities, and they always just caused a worse reaction in terms of people not wanting to get tested, as you said, even breaking out of the facilities that they saw as prisons to go back into communities. And so from my experience, I think when you give patients that information and that power, you tend to have better outcomes than when you try to, treat it as a law enforcement exercise. You need a bit of both, but ultimately the focus is on empowering patients.
Thank you. Very inspiring. Time is not from our side. I will move to the next presenter, if you agree. Thank you again, Paula, for the great presentation and great work indeed. The next presentation is about implementation of digital clinical decision support tools to improve quality of care and reduce antibiotic prescriptions for, Yes, indeed, reduce antibiotic prescriptions for children in primary health care settings in Rwanda. And the presentation will be done by Victor Pacific Gwandagarugachu on behalf of the research team. The floor is yours.
Good afternoon. Good morning, depending on where you are. Would like first to appreciate the organizers for this platform and for this high-level conference. Today, I'm going to present about Dynamic project, a project which is mainly focusing on implementing clinical decision support in tackling or mitigating antimicrobial resistance in primary healthcare setting in Rwanda. This research project is being implemented by various institutions, including Swiss Tropical and Public Health Institute, that's where I belong, Unisante, and EAPFL. I will be also presenting with Alexandra Kurikina, who is project leader, also available virtually. So going forward, I will talk briefly about the rationale of the project, our intervention, about the study design, result, recommendation, then conclusion. Mortality of under 5 children is still high, despite the increase of antibiotic prescription. Previous studies has revealed that the increase of antibiotic has increased more than 10 billion defined daily dose from 20,000 to 2015. And this is projected to be even higher if nothing is done on this aspect. Let's have an example of an 18-month-old child who have been visiting their facility different times. Let's consider this 12 visit. Among those 12 visits, 7 times the patient was having fever. Considering our context for clinician or for anyone who has been in primary health care, you can imagine how many times that kid has received antibiotics. This is not far from the reality. Among the 12 visits, 11 times this child got antibiotics. This might be due to various factors. First, that might be due to the condition of the patient, maybe was needing antibiotic really, but there might be also some aspect of skills, of knowledge of clinicians. There might be aspect of culture. There might be expectation of patient. We know some patients who come having prescription in mind, like I need antibiotic, things like that. And also, there might be some aspect of resources which are also limited in some settings. Then infrastructure, diagnostic capacity, and clinical decision support. Dynamic project is mainly focusing on the two areas, on improving the diagnostic capacity of the clinicians or healthcare settings, and mainly working on providing clinical decision support for nurse. As mentioned earlier, the main goal of the project is to improve the quality of the project, the quality of care among pediatric patients through reduction of antimicrobial prescription using clinical decision support among the frontline workers. Talking about our intervention, we are having electronic clinical decision support, which is called EPOCT Plus. EPOCT stands for Electronic Point of Care Test Plus, which is third generation of some of the previous clinical decision support developed by Swiss TPH. Another intervention that we are providing, we are also providing tests that are facilitating primary healthcare nurses to differentiate infection, especially viral and bacterial, which is anticipated to decrease the antimicrobial resistance and also the level of prescription of antibiotic during consultation. Among other tests we are providing includes hemoglobinometer and other assistance in consultation such as pulse oximeter to assist in measuring the severity of the diseases. Talking about the development of the EPOCT Plus, the backbone for EPOCT Plus is IMCI, Integrated Management of Childhood Illness. It has been evaluated from small community in Tanzania, where it revealed that for patients who are being treated by IMCI, there have been 90% of them are receiving antibiotics. Then there was a notion of going further to see if digital health can be used to decrease this antimicrobial prescription. Then they developed what is called Almanac, which is mainly digitalization of IMCI, which was mainly putting the paper document that's provided by WHO into the digital platforms. This didn't change anything about the interval covered by IMCI, which is from 2 months to 59 months. And later, this has reduced the antibiotic prescription to 30%. And the next step was about to see what can be done to make it even further, to make even further reduction. The next step was about adding assistance through point-of-care tests, such as pulse oximeter and other CRP tests to increase the precision or the accuracy on diagnosis among clinicians. This time around, we're implementing EPOCT Plus, which is going even beyond IMCI age, from 1 day to 14 years. It's early adolescent age, the formerly called pediatric age in the health settings. This EPOCT Plus is being embedded in various software that we have on field. The first one is MEDAL Creator. It's medical algorithmic creator, which we are using to develop those algorithms and adaptation of some more of their content. For example, if there are needed modification in doses or anything, those are done through MEDAL Creator. We also have MEDA Reader, which is the display of all the content of the algorithm. It accepts diagnosis, it accepts clinical signs, symptoms, suggests assessment, and also provides suggestion on diagnosis and treatment. We also have another tool called MEDA Hub. It's also a local database that we are using to store local information. At the health facility, we are having tablets which have this clinical decision support algorithm, and all those tablets are connected so that nurses at the same health facility can access medical case through different devices affiliated to that health facility. And this is being able through MEDA Hub. Later, we also have MEDA Data, which is the central server for all the content. There are also other assistive tools that are in progress, MEDA Outbreak and MEDA Monitor, that will be helping in high-level health management committee to monitor surveillance of diseases, prevalence of diseases, antibiotic prescription, and other evaluation that are needed in evaluating health system. Talking about our study design, it's a randomized controlled trial, pragmatic parallel cluster, and we so far have enrolled 32 health facilities. We are working in western province of Rwanda, in 2 districts, Rusizi and Nyamasheke, as you can see it on the map. So the way we are working, health centers have been divided into 3 clusters, and they are being enrolled in parallel. Each cluster is having 10 to 12 health centers, and among the group, there is control and intervention. So the intervention health facility, they are the one which are given all the facilities, including the algorithm, the medical devices, everything needed that we are providing for improving the quality of care. But the control health facility, they are mainly using their daily routine while treating patient, but they document all the cases that they are receiving, including diagnosis and prescription in the tablet, and then we later compare the finding, focusing on antibiotic prescription on day 0, meaning on the day of consultation. Then also we monitor the cure rate at day 7. So that cure rate is done by our call center, which is following up on patient on day 7 to see how the patient have been 7 days after the consultation. The logic of the 7 days is that we are enrolling only patients with acute illness, and on day 7 there is expectation that there might be some improvement or aggravation of the disease. For this time around, I'm going to present about the findings of the cluster 1. As you can see on the timeline, this is an ongoing project. It has been starting in early 2021, and we've gone through various processes, including validation, in collaboration with some local organizations such as Rwanda Pediatric Association, RBC, and all the requirements that are needed for randomized controlled trial, including piloting. In summary, taking this monitoring data that we are having for now, as you can see, control health facility are having more cases than interventional health facility, and also the level of completeness of cases is high in control health facilities. This is due to various factors, but we will see the variability in the health centers in the next presentation. Again, about the antibiotic prescription, you can see that there is high prescription of antibiotic in control health facility, which is even more than double the intervention prescription at day 0. If we see the follow-up done, this means I talked about day 7 chorus. We are following up on patient. Sometimes the patient may not be found because they are not having phones, and through this we are also collaborating with community health workers who are mainly helping us in home visit in case we can't find patient on phone. So regarding a follow-up done, it's 85%, as you can see, for both control and intervention. And about the cure rate, you can see that it's the same. So talking about the uptake, which is a completion of cases, you can see that there is high case completion in control and around minimal case completion in intervention. This is due to various factors. As I talked about this is a dynamic project, so the tool we are using, we are getting some time of maintenance. There might be some time off for maintenance, but also some facilities are having different number of patients. So those which are busier, they might enroll few patients because their main priority is mainly to complete all the, to treat all the patients who are coming for care. For antibiotic prescription, we can see that it's very low in intervention health facility, with one outlier, a health center, where we might find that despite suggestion of the clinical decision support, clinician might even still add antibiotics, but this will be further analyzed qualitatively because we are having mixed methodology of research that to understand the effectiveness of this tool. Talking about the challenges, I talked about the tool which is under development. As you can see, implementing a tool while developing it, there might be some challenges on field regarding use. The other challenge is about the complexity. Before initiating this intervention, you have to do the health facility assessment to see how health centers are ready to receive this intervention. And this has contributed to our structuring our methodology, but also we are having quantitative research, also quality of care assessment to see how patients are receiving this intervention. And also we also follow it up with the district health management team to follow up to see if there is any impact that is can be seen through the overall health data in the region that we are working in. So regarding recommendation, there is a need for intensive training and mentorship for clinicians because this tool is combining aspects of IT and clinical, and we know when it comes to IT, not everyone is easily adaptable. This is need a huge follow-up and mentorship to have this in hand and to reach this success. The other point is about interoperability of digital health system. On various health facilities, they are having their ways of recording things. Some are still using papers, others are having some advanced health system, and there might be some which are working the same way. So there is a need for interoperability, of having a way of incorporating those systems so that we will have one system that will facilitate everyone to find data for clinicians. It's in line with one patient, one record. I think this is already in the way. The last recommendation is mainly about engaging more community and government to join hands and get involved in this to increase the sustainability of this intervention, acceptability, and also the completeness of this of mitigation of antimicrobial resistance. As a conclusion, electronic clinical decision support can reduce antibiotic prescription among under 15 children, and without any compromise in the cure rate. This is the whole study team and a big list of partners. I would like to thank you for your attention, and questions or any recommendation are welcome. Thank you so much.
Thank you, Victor, for the presentation and for this very interesting study. Rational use of antibiotics is still an issue here in Rwanda, and finding strategies to help clinicians to diagnose first the diseases so as they can prescribe necessary antibiotics is very important, and leveraging digital tools. And that's what we've been doing to test if these digital tools can help in contribute to reduce unnecessary utilization of or use of antibiotics is a very important work there. Thank you for that. Let's go through questions again and comment.
Thank you for the presentation. I have two small questions. The first one, I'm curious to know the cost of these diagnostic tools, and this goes with the scaling up of the spreading of the tools across the country. How will it cost if it becomes successful? The second one, you showed that the cure rate. You said it's similar in both arms, 89%. What about the remaining 11%? How many get worse? How many stay longer in the hospital? How many dies comparing the two arms? Thank you.
Thank you so much for the question. About the cost of this process, yes, it's expensive compared to the routine care, but it's so far about the way about taking this forward. There is an ongoing engagement of the further governmental involvement to assist in sustainability of this project. This will mainly involve ownership of the interoperability of system, ownership of the government institution, and also this will be a bit expand the impact of the project. So regarding the cost, I will not say I have a specific amount regarding this, but it's showing an increment in the standard of care that kids are receiving. So talking about the death rate or the cure rate, the 89% is for, as you have seen, there are people whom are lost to follow up. They were not counted, just for clarification. And then for 89%, there are patients that you might call and you find that they got complication on their arrival at home. They have been hospitalized or referred to for further care in other hospitals. So those patients are included in those 11% who are missing.
Thank you. Let's take one more question, then we'll move to this last presentation. Yes, please.
Thank you very much. My comment is on the daily dose usage. You said about 12 visits that are done, and the under 15 or under 5, was it under 5 or under 15? Under 5 are receiving antibiotics. In the districts you're in West, you said about which district? Rusizi and Nyamasheke, where you've started piloting this. What have you so far helped them to either reduce the continued prescription of the antibiotic? One of the reasons you put down You talked about either condition or skills or culture, expectation and all that. And I expected to see one of the challenges I think doctors and clinicians are facing is not being able to access what we call a shared health record, to be able to know that this under 5 has actually been seen by another physician and has received another prescription. So if they do not have that visibility, they tend to really do the same mistake again and again because the visibility is missing. So with the Chief Digital Officer's presentation earlier this morning on the Health Information Exchange project that is being developed, mine was just to see how that will be linked with your project to ensure that we facilitate our doctors to have that visibility through the shared health record and through the patient roaming, which will be enabled through the patient unique identifier, because you need to know that patient A is the one who has moved from Nyamasheke to Rusizi to Chiwungo to anywhere that patient is moving, so that you know that you're not going to prescribe the same antibiotic again and again. Thank you very much.
Okay, thank you so much for the question. This we make me go a bit on the flow of patients when they are being enrolled in the study. Actually, in this clinical trial, patients are getting the unique ID identification, and we are having a representative on each health facility who is registration assistant to receive all the patients, explain all the consent process, and give them the code. So when the patient receives the code, he is requested to bring that code always when he comes to the health facility. And when he comes back and they scan that code, we are able to retrieve all the information that the patient had given before, meaning we can track the clinician can track the previous consultation. This is being done through that medal hub that we are having at the health facility, where all tablet affiliated the health facility are able to retrieve all the information of patients whom they have their QR code or unique ID, and that will also facilitate clinician to know if the patient have been given antibiotic previous time, and it will remit always prescribing the same drug for a week, for a month, and that will also recommend if the patient need a referral or need any further care for better management. Thank you.
Thank you. We have one more question online from Alexandra. Alexandra, please introduce yourself and ask your question.
Good afternoon, everybody. Actually, I don't have a question. I just wanted to contribute a few points to the questions because I'm the project leader for this project. Thanks a lot for your great questions. I hope you can hear me well.
Yes, we can hear you.
Great. So just a few clarifications. This is a very big study, and we're only presenting preliminary results of one group. So we still have 2 more groups to go to make any generalizable statements. So these are very preliminary results, including those of the cure rate that was asked by one of the gentlemen as to what is happening with the other 11%. More in-depth analysis is certainly planned and will be disseminated when we're completed the whole study. We also have a cost analysis planned, so this intervention, before we present the case for potential scale-up or additional health facilities, will also be included. And then Victor mentioned we have mixed methods research as well, so we do have some health facilities that are performing really well, and we have some that are lagging behind. So despite the intervention, they're still prescribing more antibiotics. So we have qualitative and quantitative additional research into that that will be available. And then my last point is about the patient record. While we do have a limited patient record included as part of the intervention, it's not a comprehensive, it's not, this tool was never meant to be an EMR because those software are existing already. But we saw that there was a limitation of those EMR, electronic medical record software, to develop and deploy and adjust clinical decision support algorithms. So the complexity of the outpatient algorithms are not well handled by the current software. So we developed this software specifically for that. So our next step is to look at interoperability and data exchange with other EMRs that would be existing in the health facilities by the time that we're done with the study. Thank you very much.
Thank you, Alexandra, for bringing those clarifications. You said it, this is a study that you're still starting. We'll probably having more and more findings, and we'll be happy in our next symposium to have you again come back and present more findings around cost analysis, more findings about effectiveness, acceptability, more qualitative research findings as well. Thank you again for taking time to present this work to us. And let's give again a round of applause to the presenter. Thank you. Then last but not least is Hassan Mugabo, who will be presenting about removing barriers to effective data use with the Rapid Data Integration Platform in Rwanda. Hassan, you are welcome.
Good evening once again, and thank you very much for giving me this opportunity to present on on our project that made us remove barriers to effective data use with the use of Rwanda Health Analytics Platform. And I can't also start without thanking the organizing committee to have this to have this symposium well organized like this to its success. So as I said, our presentation is about removing barriers to effective data use with the use of Rwanda Health Analytics Platform. And this was a result of having many fragmented data sources, and these silos could bring about a difficulty in having or in making the analytics of data, as these data sources are, as they are different, they are also different in structures. They collect data in different formats. So my presentation is about describing the design, functionality, and the implementation and the nationwide scale-up of this system, the Rwanda Health Analytics Platform. So if I start with giving the background, it was in, I think we can go on the next slide, please. Yes, starting from 2016, RBC decided to create interactive dashboards for each of its divisions. And this, as it was starting to be implemented, there was a difficulty in integrating these data sources, as I said earlier, because of the difference in the data sources in terms of structure and the format of the data. So from there, RBC and the Ministry of Health decided to engage Zenesis to have the integration of this data from these different data sources. So that's when the creation of the Rwanda Health Analytics Platform started. The next slide. Yes, on the next one. Yes, now this integration after engaging Xenesis was done in 2 phases. First phase that was that integrated the main data sources that collect mainly the aggregated data from the ground, and then after this first phase, there was also an interest in also integrating the ELMIS data and also integrating the updates of the already existing data sources into the system. So the slide shows the data sources that were integrated in the first phase, and also the ones that were integrated in the second phase. Now the system, all it does after importing the data, it does the cleaning, and then it gives a way to make the analytics easily, while all the data are put into one place for easier analysis. The next slide. This also shows the data sources that were integrated into the system, including the HMIS, the SysCom data, and also we recently have also started to include the COVID-19 data. Next slide. Now, after the integration of the data set, we started the rollout of the system to the decentralized users so that it can benefit the users at this decentralized level. So the integration of the platform was about helping them to generate analytics within their routine workflows, including tracking district performance indicators. There is generating visuals for routine data review meetings, customized data dashboards used to track performance indicators at the hospital and the catchment area. And also, next slide. And after that, there is also data dissemination and use. That is the development of official health program dashboards for RBC divisions. And on first, we created the dashboards for malaria, mental health, NCDs, HIV, and MCCH divisions. And also to support the Ministry of Health to integrate use of the platform into their routine workflows by facilitating the routine health analytics use, including the tracer drug stockout monitoring. There is RHAP data consistency checks before the reporting period ends, because there is every month there is a deadline for reporting. So before the deadline for reporting, there is an activity, or there is a way to check the data consistency, and also the district and facility level analytics for presentations by leadership, and the routine quarterly and the annual report. Now, next slide. As a conclusion, after this success to enable the analytic, to enabling to provide a way for analytics from the central to the decentralized level, Then RHAP is also recommended as an analytical platform for RBC programs in the 2021-2026 National Research Innovation Data Science Strategic Plan. And as a way forward, RBC and Genesis are also working on the expanding of the scope of the RHAP by including the integration of laboratory information systems into the RHAP, and also COVID-19 testing app system, and the individual records databases, data sets. As I told you at the beginning, we had started with integrating the systems that collect aggregated data. Next. Yeah, I think this has been the shortest, but I think I have tried to give you everything that the system is all about as a solution to answer the difficulty that is being brought about having many different sources of data, and it and makes it difficult to have the analytics. Thank you very much. I'm looking forward for the questions.
Thank you, Hassan. And let's just quickly jump into questions. Yeah, there was someone online who had a question. Is the person still available there?
Yes.
Okay, let's start with those online, then we'll be asking questions in the room. Yeah.
Okay, thank you for the presentation. So I want to ask if those data are available for public users, and if yes, at what level for aggregation, and if no, what are the requirements to be able to access data for further analysis?
Yes, thank you very much. First of all, yes, that I can say yes, that this data that are there for public users. First of all, these dashboards that are being created are created for public consumption. And secondly, if there is a need for having maybe raw data that is for your public, for your use, there are processes that one go through, and they request the data from the concerned division, from the RBC. So I can say that yes, data is there for public consumption, and maybe I didn't. Secondly, for the level of integration, if I had it very well, is it the level of integration as in?
I mean level for aggregation, so it should be like individual data should be aggregated at a certain level of administration or at a certain level of population.
Yes, thank you very much. As I said earlier in the presentation, we started with systems that capture aggregated data. Then now, as a way forward, we are continuing the way we can expand the system and start also to include in the systems that capture individual records.
Thank you. More questions? Yes.
Thank you for the good presentation. You did mention individual record integration. Is that the EMR data? If not, what are the plans? And then I also wanted to know, in terms of going or scaling up, you mentioned Musanze as one of the districts. Is this going to be national? And third question, how different are these dashboards from the existing DHIS2 dashboard? Is it DHIS2 plus, or are they totally different from the existing dashboards that DHIS2 has? Thank you.
Yes, thank you very much. Let me start by the last question, going upward. Sorry. They are not DHIS2 dashboards, because DHIS2 systems are also among the systems that are integrated into RHAP. So RHAP has its dashboards that are created by combining data from different sources, including the DHIS2 systems. Then for the individual records, well, there is the EMR records. Those are also individual records. And we quite have a number of services that we offer in our facilities that capture individual records, including TB service. They capture individual records. So those are the records I was talking about that we are yet to start including them into the system. And then for the scale-up, we mentioned the Musanze as because it was among the pilot areas, but we have already scaled up nationwide, and of recent we have trained all the data managers from district hospitals to start using the RHAP in their routine reports.
Thank you. I also have a follow-up question. In terms of the future, did you think about, because what we are presenting here is integrating different existing data sources, but I think better it would be to have just, if possible, one combined source of data in a way that you do not need to have that continuous work of integrating, cleaning, and then so as we can be able to analyze the final data set. What is the future here?
Yes, thank you very much. Actually, that is the solution that RHAP brings, because after reporting into these different data sources monthly, then what RHAP does, we have two phases of data pull into the system. Pulling those pulls, they pull data that is reported from different sources, and they are put together into one database. So now when you start to analyze, you just find data from different sources that are put together. You don't have to go into different sources. So, and also, these data are ready to provide analytics because they undergo cleaning, all the necessary cleaning. Then for the user is just finds data that is ready for doing the analysis that is needed.
Thank you. More questions? Yeah. Yes, please go ahead.
My question goes around the data structure from different data sources you are pulling from or importing data from. For example, if we may consider data around COVID-19 from different data sets that have been put together in this health analytics platform. So how do you deal with the different data structure? I guess you think of, or you do something of a common data model when you putting, or when you reach the analysis stage. How do you deal with this? And I think this will also be something to consider when you reach the individual patient data, when you will be pulling data from different EMR systems. So how do you deal with this? Thank you.
Yes, thank you very much. I think for the individual records, as we are planning to expand the system so that we can also start to capture them, that's when we shall also implement those data models that can be able to help us deal with the individual records. But for now, we are capturing aggregated data. And I think we don't have those special data models, I think, to implement for now. I don't know if I have responded well to the question, or there is more clarity.
Are you satisfied? Okay, you want to...
Could you repeat it?
Follow up?
What I mean with different data structure is like the terminologies, the dictionaries, and which these data are stored with. I know when you think of these aggregated data, is it only frequencies or percentages, or you have some more data that have different data dictionaries that when you are pulling in something common, you need to harmonize these?
Actually, the frequencies are made by, are calculated or are made by RHAP when you want to do the analysis. Otherwise, the system just pulls data as in numbers as they are reported from the field.
Yeah, I think you can keep discussing offline after this session. I'll take another question. That will be the last one before we close the session.
Thank you, Hassan. Thank you for the very clear presentation. I just want to ask about data use. Mostly when you talk about data, we usually focus on the collection, and when it comes to use, there is a tendency to focus on using it for higher level decision makers only. I'm happy to hear that you have already trained data managers from district hospitals. I want to know if there is any plan to do for health centers, for health center data managers, as well as head of health centers. So those are the ground level, like the grassroots level data users. Training them on the use of the system will also improve the quality of data. I just want to understand the future plan in terms of health centers and users at health centers. Thank you.
Yes, thank you very much. As you've said, we started with the central level, then after making sure that the central level can use the system to help doing the analytics to answer their routine, to have the report in their routine reportings. We also thought of decentralizing the system to lower levels. So by now, we have started with the data managers from the district level. Then I believe after that, the scaling up will continue to lower levels, that is the health center, because they also have data managers that report, and there is also a lot of data that comes from the health center. So for now, it will help us also to have data that has not much problems to be corrected. But as of now, to respond to the question of data that might come from the health center level that has problems, we provide that chance of exposing the problems they have before the deadline of closing the reporting, so that they can have some days to correct the data. So these data managers from the district hospitals that access the system, that understands the system now, they also have a responsibility to supervise the health centers under their catchment areas. So after identifying the problems, they also have that responsibility to tell them to correct the problems that are identified before the deadline for closing reporting. Yes.
Thank you, Hassan. Thank you for the presentation and the great work to improve the quality of the data for better decision making. This is the last presentation. I thank all the presenters. I thank the audience, all of us, for the great questions, the discussions that will help to advance this conversation on how we can leverage digital tools to keep improving health systems. Thank you again. And for the next item on the agenda, now it's time for poster presentations, and there is also a coffee outside, and I think that is the last item for today. And we look forward to see you again tomorrow morning for very great presentations as those of today. As well, we'll have a keynote speech again and many great presentations. And you are invited to join also the program for tomorrow. Thank you again and have a great evening.
A few housekeeping, please. If you have not received the abstract book, you can just